Okay. Hello, good afternoon, good afternoon, good afternoon. We've had a longer break than all the other days, so I hope everybody is back here. Before we start the next session, a few announcements. I've asked Dr. Claire Fuller to introduce the group of the International League of Dermatology Society here, who are in the organization now, and for us to see them, welcome them to this important meeting. Claire, you have the floor.
Thank you very much, Kingsley, and it's a great pleasure to introduce to you at this first of its kind Skin NTD meeting at the WHO, the ILDS, the International League of Dermatological Societies WHO committee, who are here for this meeting, recognizing how crucial this event is, and they really wanted to be here to meet with you all and to exchange pleasantries, but also they won't do that now. But I just thought I would introduce them. They're all sitting in the back row here. If they stand up, and I'll just run through. Lars, so we'll start from the right-hand side. Jonathan White from Belgium and the UK. Lars French from Munich. Christopher Griffiths from the UK. Sven Multe-Jung from Germany. Carsten Floor from the UK, and Esther Freeman from the States, and Rod Hay, you all know, from the UK, and myself, obviously, yeah. So just to say welcome, thank you. So please, if you get an opportunity and you want more commitment from the dermatologists in what you're doing, we're the guys to come to. Collar us while we're here. Enjoy the rest of the meeting.
Okay. Thank you very much, Claire. Now, colleagues, today is day 4 of the one-week meeting. Tomorrow we'll be wrapping up. May I ask all of you, whatever ideas you have, suggestions you have, recommendations you have, technical or strategic, for moving this effort forward. Please, if you are online, you can, or in person here, you can send emails to us, Stephanie, Priya, and myself. We will compile them. If you are online, you can also put them in the chat. If you are here and you want to put your comments, recommendations, action points, whatever you want us to take away, please try to put something by tonight, so that tomorrow we will summarize all for the end of the meeting, conclusions and recommendations. I encourage you to do so, because if we are able to organize this well, then tomorrow it will be easier after the first session on operational research. Then the various chairs and a group of selected rapporteurs can put together the conclusions and recommendations before the DG comes, so that we have something ready to share with him. So I encourage every attendee, in person and online, to provide something for us to take away tomorrow. Please do so by end of today or tonight, so that tomorrow in the morning the work will start to compile them. Yeah, you can do it. Yeah, today, starting now. Thank you very much. I have heard many comments from many of you already. Very good comments. I recall one saying that, oh, it's very good to be here, because WHO meetings, you don't have to pay for registration fees, which is true. WHO meetings, maybe the visas are not as hard as you get for going to the United States, for example, or UK these days. So there are a couple of advantages why we can sometimes meet here. But anyway, whatever you have heard from Monday up to today, we have only left with one session tomorrow. So by the end of this afternoon, we'll have covered almost 8 out of the 9 sessions. So you can already write what you think should be the way forward. Thank you very much. Now, I leave the floor to the chair for this afternoon session.
Thank you, Kingsley, and good afternoon, everyone. And welcome back after lunch, and welcome back to all of our online attendees. And as Kingsley has said, this is our penultimate session, so I hope you're still full of energy for this last leg. Today we're talking about treatments, and our first speaker today for the keynote presentation is Professor Richard Phillips. He is the Scientific Director of the Department of Medicine and the Kumasi Centre for Collaborative Research in Kumasi, Ghana. And he's going to talk to us on drug treatment, review of current drug treatments for skin NTDs, opportunities, challenges, and priorities. So, Professor Phillips, we're very much looking forward to hearing from you. Thank you. You have the floor.
Thank you, Michelle. Thank you for this opportunity to do this review. I know there are lots of dermatologists and experts here who could have probably done this, but I'm also happy to do it. Looking at treatment for skin NTDs, I think is a very important part that we need to consider at this stage. Because when it comes to control, eradication, elimination, treatment forms a very important part. I mean, this morning we dealt with lab diagnostics. That forms another important part of this. And for the 2030 roadmap, it could be frustrated if challenges and priorities relating to treatment are not addressed. Because you notice from the review that some diseases do have good treatment and others are lagging behind. But to draw everyone along, we need to deal with the challenges that are facing us. So in the review, I'll look at these diseases that are listed, including tungiasis. Starting with yours, we all know that azithromycin is available and is effective. Clinically is already in use. Alternatively, we have benzathine, penicillin. And so what are the issues with yours? The key issues are that does resistance emerge after MDA? Because now we know potentially we could use the azithromycin for MDAs. How do we best mobilize patients? And the other issue is whether the effect of community mass treatment on yours-like lesions like Haemophilus ducrei and others. And also how many rounds of MDA for interruption of transmission. So even though we have an effective drug, there are other issues facing us on how to get these drugs to the patients where they are. With leprosy, we have multi-drug therapy, which is effective, but there are some rifampicin-resistant cases noted in a few highly endemic countries, but the numbers are very low to consider this a threat to the current therapeutic regimen. Currently, rifampicin, dapsone, and clofazimine, it's used either for 6 months or for 12 months. And since the introduction of MDT, we see the numbers for leprosy, the prevalence going down considerably, but new cases continue to occur. And we need to think about new tools that are required for reaching elimination. And also chemoprophylaxis can be considered for preventing the risk of transmission of infection. And for chemoprophylaxis, currently single-dose rifampicin is proposed, but this intervention shall be implemented only by programs that can ensure adequate management of contacts and consent of the index case to disclose his or her disease so that the contacts may be found. For the drug-resistant leprosy, there are different regimens that are available for use, and those are the ones that I've put up on the screen of fluoxetine, minocycline, clofazimine daily, and then for 18 months, you have a fluoxetine, minocycline, or minocycline plus clofazimine. So these regimens are available and may be used for treatment. For onchocerciasis and filariasis, I put them together. There are drugs available that are being used for preventive chemotherapy in combination depending on where and which country it's being used in, but they are mainly used for clearing microfilaria. But the issues are none of the medications are effective macrophilaricides, and those are the issues that you need to think about. Doxycycline has been shown in some studies to kill the adult worm, but it has to be given at 200 milligrams daily for 4 to 6 weeks, and some studies show that they may prevent lymphedema from getting worse. And moxidectin, another microfilaricide, is under consideration as a potential MDA drug for both onco and LF. So the gaps really are safe and effective microfilaricides and also potential drugs that can reverse lymphatic dilatation and improve lymphedema. So those are still things that can be thought of. And for Buruli ulcer, we know rifampicin and clarithromycin has been implemented after clinical trials daily for 8 weeks with minimal side effects, no recurrences. It's a full oral regimen, but we all know that the administration is prolonged and there should be efforts at shortening this therapy. A cost-effective approach is what is needed. So there are ongoing clinical trials, a number of them going on, BLMS for BU in Ghana, Cote d'Ivoire, Benin, and Togo, where rifampicin is being used together with clarithromycin and a third drug, amoxicillin clavulinic acid, comparing that with the standard of care. And that study is ongoing. And Buruli-Rifdac, where high-dose rifampicin at 20 milligrams per kilogram body weight rifampicin is being combined with 15 milligrams per kilogram clarithromycin compared with the standard of care. And the third drug, the third trial is Buruli-Nox, where 10 milligrams per kilogram rifampicin is being combined with 15 milligrams per kilogram clarithromycin, together with nitric oxide releasing dressings that have been shown to also kill the organism. And that is being compared with standard of care. Lately, there are new drugs on the block, and one of those is Q203 or Telacibec, and a lot of work has been done, and a few publications are coming out lately. It's been shown to be highly potent to rapidly decrease or to rapidly kill the organisms. And with the study up there, it showed that there were samples were culture negative after 2 weeks of treatment with regimen containing rifampicin, clofazimine, and Q203. And there was no relapse after 2 weeks of Q203 containing regimen. But subsequent to this, there are other studies that show that even this drug could be given for a shorter period, and it could kill the kill the organisms, Mycobacterium ulceram. So there's a lot of interest in this new drug, and recently Curient has partnered with TB Alliance to develop Telacibec for TB. But we think that Buruli ulcer, leprosy will potentially benefit from this as well. For cutaneous For cutaneous leishmaniasis, there are issues. There are many options for use by clinicians with the pentavalent antimonials. They are available, IV, IM, or intralesion, liposomal, amphotericin B, and meltifosine. And also you have the azole drugs, fluconazole, ketoconazole, itraconazole, pentamidine and topicals. They've all been proposed, but there are big issues. Failure rates are significant, toxicity considerable, relapse common, drug resistance emerging, and IV, IM use problematic, treatment prolonged, cost substantial. And so these are troubles that are facing the skin NTD community. We need to look at the best way forward, at how to provide the ideal target drug. And so we need to look at what could be ideal and efficacious drug against all species, at least with at least 95% efficacy, maybe easy to use short course, maybe 14 to 28 days regimen sort of, with no interaction if given in combination, leaving minimal scars, safe in pregnancy and breastfeeding, affordable, and that could be adapted to tropical climates with prolonged shelf life. So these are things, the skin NTD group, we need to be looking at how to address this. It will significantly improve our chances of better care for such patients. And then back to mycetoma, we've heard a bit about mycetoma caused by actinomycetes and fungi. For treatment of the actinomycetoma, the bacteria version, treatment could be for up to a year. Different combination drugs, cotrimoxazole with amikacin, or cotrimoxazole with amoxicillin and clavulanic potassium, and other regimen, few other medicines that are in use but are in a small scale. For the mycetoma, that's the fungal version, itraconazole, given till cure, voriconazole till cure, and some studies have used liposomal amphotericin B, and some have combined with surgery, but there are challenges. I mean, the treatment outcomes not always so good. Long treatment with antifungals combined with surgery, recurrence is common, non-compliance high. These are issues we need to try to deal with as a big group now that we are going integration. There's this proof of concept study that I found with fosravuconazole versus itraconazole for mycetoma in Sudan, where for one arm you have fosravuconazole at 3 milligrams and also at 2 milligrams in another arm, again standard itraconazole 400 milligrams daily, and with the hope that one arm, either arm 1 or 2 will be dropped after 3 months. So that's one of the studies I found. But there are gaps in knowledge that we need to think about addressing. Could we find new compounds that are not azoles? Better standardized treatment, as current treatment differs per country and depends on the organism isolated. Could we find better options? We need to probably explore correlation between in vitro sensitivity of the azoles against in vivo clinical response. These are all questions that need to be flying in our brains as we go along. Post-Kala-Azar-Dermal leishmaniasis is another one that affects individuals with previous visceral leishmaniasis caused by Leishmania donovani parasites, and they cause hypopigmented macules, papules, nodules, or combination of these, and they drive inter-epidemic transmission of visceral leishmaniasis outbreaks if not treated. And treatment options, what are they? We have the sodium cibogluconate, 20 milligrams per kilogram, 20 days per month for 6 months, and there are issues. I mean, it's painful, and there are cardiac complications, sometimes death. Alternatives are there, like miltefosine, oral for 12 weeks, that has about 81% efficacy. But safety of long-term treatment, including in children, we need to establish those. And amphotericin B also may be given. It's also really prolonged treatment for 4 months. I mean, it's nephrotoxic and it's high cost. Liposomal and amphotericin B is also an option. Most of the study sizes have been small. So there are options for us to really stretch ourselves as a group in looking at better options for treating those. And for scabies, we have topical benzyl benzoate, usually administered at 25% applied over the whole body, relatively cheap. Sometimes it causes skin irritation. 5% permethrin cream for topical use is also available. And then ivermectin, that could be, you could have 2 doses maybe given to all except pregnant women and infants. But there are issues there too. I mean, the risk of reinfection and community transmission, I mean, high if patients and contacts not adequately treated, and how to distinguish reinfection from primary treatment failure, as rash and itch could persist for a little while. These are things to think about. And then the other bit is to look at opportunity for MDA with ivermectin. There are a number of studies that are online. Recently, there was one study that showed that 1 dose is not inferior to 2-dose ivermectin. But really, most of the MDAs that have been done in island populations, and we need to look at non-island populations, looking at how this drug could be used in non-island populations to achieve better outcomes. So that's food for thought. And then the last one is tungiasis. I mean, tungiasis caused by female sand fleas embedded in the skin, mostly in the feet. What treatments or options are available? Surgical extraction is an option of embedded sand fleas, but we know that removals can be painful and poorly tolerated by children, and the risk of secondary infection is also there. Topical application of a 2-component dimeticon is an option. It's known to make the organisms non-viable. And there have been RCTs looking at antiparasitic agents that have not been so effective. Benzyl benzoate has been tried, and some anecdotal studies say maybe it's effective, but no proper trials. And then there are other agents that have been tried for use, but complications still a problem: abscesses, secondary infections, gangrene, disfigurement. So these are problems that we have with the skin NTDs, and as a community, we need to interrogate these. And this is just a summary slide showing that you can see that some of the skin NTDs have effective treatment, others don't have effective treatment. A lot of them are given for prolonged periods. We need new drugs that can be given for shorter periods. And some don't have good medication at all. And as a group, we need to think about these. For those that have proper drugs, how to get them to the patient, improving access to care is a big issue. For example, with yours, we have good treatment for a while, but are we reaching everyone with this drug? How to get these to the patient is a big thing. And then for those that don't have the required or the best of medications, we need to think about having new medication for these. So I think there's a lot of food for thought for the skin NTD integration, and we all need to think about these and find solutions as we go into integration. Thank you very much.
Thank you very much, Professor Phillips. You've really given us a very full overview of all the current treatments available for the skin NTDs. I think you've covered just about every condition, so you've set us up really nicely for this afternoon's session, but you have highlighted the need to increase the number of treatment options available, and certainly for those where we do have drug treatments, that we are desiring shorter treatment regimens. But thank you very much for that. We're going to move straight on to our next speaker, please. And I'm very pleased to introduce Barbara Milani. And she is a consultant here in Geneva for the WHO Global NTD programme. And she's going to talk to us about the results of the 2022 Global WHO Online Survey on diagnostic capacities and treatment practices for implantation deep mycoses. Thank you very much, Dr. Milani.
Thank you. I'm going to present on behalf of the core team, which has conceptualized the online survey. The report of the online survey, the results will be available in a few days. We are just waiting for the production clearance. So we'll just introduce some of the main results. The survey was conceived as part of a WHO collaborative agreements and project with the US FDA to identify priority diseases for pilot testing of CureID. CureID is a mobile and web-based platform which has been developed by US FDA and the US National Institute of Health to help clinicians share their experiences in managing difficult-to-treat diseases, and in particular to inform clinical research needs to support repurposing of approved medicines for new clinical uses. Since 2019, WHO has been performing landscape analysis to identify difficult-to-treat diseases where CureID could have an added value. And in 2021, we performed an initial inquiry with 12 experts, key informants, working on mycetoma and other implantation mycoses to see if there was drug repurposing occurring in middle-income countries. There was a positive outcome from this initial inquiry, and therefore WHO decided to undertake a global survey to consolidate these findings. The WHO Global Online Survey on Implantation Mycosis aimed to collect data on diagnostic capacities and treatment practices, including pharmacological and non-pharmacological treatments for 4 implantation mycoses, for the 2 forms of mycetoma, eumycetoma and actinomycetoma, but also on cutaneous sporotrichosis and on chromoblastomycosis. The main objective was really to inquire if drug repurposing was occurring in middle-income countries for these implantation mycoses, while considering diagnostic challenges, the use of non-pharmacological treatments, and challenges posed by the availability and or the affordability of medicines. The survey was conceptualized using a mix of information sources, starting from the key informants' interviews, the data provided, and the published literature. It was designed using multiple choice options with the possibility to provide additional entries and comments for every question. There were general questions to inquire on the respondents' profile, their country, their setting, their professional role. There was one general question on the diagnostic methods used and available in the respondent setting, and one general question on the medicine's availability and affordability. For each implantation mycosis, there were specific questions inquiring on the medicines used, and where applicable also on the non-pharmacological interventions used and applied in the respondent setting, as well as on the presence of refractory cases. To overcome language barriers, the survey was also translated into French and Spanish. It was created using the WHO official survey tool, which is called the WHO Data Form. It was opened for around 2 months, from 7th January to 15 March 2022. We have attempted an extensive dissemination through different channels, through the key informants of the initial inquiry, We reached out to global and regional associations on dermatology, mycology, and NTDs. We reached out to working groups on implantation mycosis, and also we attempted some social media dissemination through LinkedIn and Twitter. The International Society on NTDs also hosted a webinar for the launch of the survey, which is available in their YouTube channel. The survey analysis was partly generated by the WHO official survey tool for the yes, no, and the multiple choice answers, while for the free text options and comments, these were separately considered, aggregated, and analyzed. And the preliminary analysis was also shared internally to WHO, US FDA, and the Public-Private Partnership, CDRC, and to some external WHO advisors and experts, and their feedback was incorporated. The results of the survey should be considered in light of the survey coverage and also of the respondents' profile. We received answers from 142 respondents from 47 countries, including all continents, all WHO regions. 60% were from middle-income countries, 59% were working at tertiary level, and 30% at the secondary level. Here are some of the graphs that you can find in the report. In the report in the annex, you will find also much more detailed information on number of respondents by country. The general question on the diagnostic methods available for implantation mycosis provided some insights on which diagnostic methods are available. We also did a disaggregated analysis by level of the health system, primary, secondary, and tertiary level. And in general, at primary level, there is a lower availability of diagnostic methods beyond visual inspections. In terms of treatment practices, the survey confirms that drug repurposing is occurring for fungal diseases beyond itraconazole and terbinafine. For eumycetoma and chromoblastomycosis, newer generation azoles, posaconazoles, and voriconazoles were used in a range from 27 to 41%. And for eumycetoma, there was also quite an important use of amphotericin B injectable reported by the respondents at 36%. For chromoblastomycosis, there was also consistent use of oral flucytosine and topical imiquimod at 14 and 11% respectively. And for sporotrichosis, there was also considerable use of oral potassium iodide beyond itraconazole and terbinafine. For actinomycetoma, there were several antibiotics from several classes used in oral and injectable forms, suggesting a high level of drug repurposing. And in relation to non-pharmacological treatment, 82% of respondents treating eumycetoma indicated that surgery was applied in their setting. Also, in chromoblastomycosis, 53% of respondents reported the use of non-pharmacological interventions. In addition to heat therapy, there was also quite an interesting use of cryotherapy and surgical excision. The survey also provided some insight on the refractory case rates for chromoblastomycosis and sporotrichosis. 68% of respondents treating chromoblastomycosis indicated the presence of refractory cases, and 34% treating sporotrichosis indicated the presence of refractory cases. On the general question on availability and affordability of medicines, over 50%, precisely 56% of respondents indicated that they could not use medicines because not available or affordable in their setting. So these are some of the figures that you will find in the report. This map you will not find in the report. We did an additional analysis of the WHO survey data looking at the treated implantation mycosis by country. Obviously, we should take this information with limitations because we had a limited number of respondents. But it shows that there is the potential to address epidemiological gaps while collecting treatment outcome information. In conclusion, the implementation of a global case report registry for implantation mycosis could contribute to address gaps in the epidemiological information and collect valuable observational data on treatment outcomes, which could be used to inform treatment guidelines and also clinical research. The pilot testing and use of openly accessible, publicly funded QRAD platform, supported by the implantation mycosis community of practice, could offer the opportunity to collect data in a consistent and structured manner. The barrier to accessing medicine should be investigated further, but definitely they should be considered while prompting and using the data generated by QRAD to support clinical research hypotheses for drug repurposing. And finally, the survey findings suggest that evidence-based guidelines are warranted and should address the entire spectrum of pharmacological and non-pharmacological interventions used for these implantation mycosis. Next, okay. To end, we would like to acknowledge all the WHO staff who have supported the development, the dissemination and the translation of the survey. A special mention and acknowledgement goes to Roderick High, David Denning and Kingsley Asiedu for their advice on the conceptualization of the survey and the analysis of the results. We would like to thank, as WHO, the survey participants, all the survey participants, as well as all the individuals and organizations which have contributed to disseminate the survey. Many of you are attending the meeting online and in person. And finally, the financial support to implement this survey comes from the WHO-US FDA collaborative agreement. Thank you.
Thank you very much, Dr. Milani, and congratulations on conducting a successful survey with a good number of responses, over 140 people in 47 countries, and demonstrating the variety of diagnostic methods in various countries and the different treatments in use. And your proposal for a global case report registry certainly is interesting and will provide better epidemiological data. So thank you very much. We're now moving along, and our next speaker is Professor Catherine Bouke de Jong, who is at the Institute of Tropical Medicine in Antwerp, Belgium. And Professor Bouke de Jong is going to talk to us about the safety of bedaquiline plus rifampicin for leprosy post-exposure prophylaxis preliminary results. Professor Catherine, the floor is yours.
Thank you very much, Michelle. And so I speak on behalf of a very large team on the safety of bedaquiline and rifampicin for contacts exposed to leprosy. So the Comoros is the only African country that has not yet gone below the 1 per 10,000 elimination threshold for leprosy. It's an island nation located between Madagascar and Mozambique. And this incredible control team, funded by the Damien Foundation, they have been going above and beyond the recommended control measures for decades and still see very high incidence. So on the left you see 3 siblings with multibacillary leprosy. And on the bottom right, Dr. Yunusa Assoumani is a clinical epidemiologist and motor behind this strong team. And as he could not present these data here himself, I am showing a short video.
Ici aux Comores, la lèpre est endémique, il y en a beaucoup de cas. Nous dépistons annuellement plus de 300 cas de lèpre dans cette île. Et nous, notre objectif, c'est de faire en sorte de dépister tous ces cas à temps pour essayer de réduire la possibilité de développer des incapacités, c'est-à-dire des mutilations, pour que ces malades-là ne deviennent pas des invalides. Donc notre objectif, c'est de chercher des partenaires un peu partout pour que nous puissions effectivement non seulement de traiter, mais aussi de prévenir donc alors cette maladie. Et c'est ça ce que nous sommes actuellement en train de faire.
And so this prevention that Yunusa alludes to, we've been testing the WHO recommended post-exposure prophylaxis that Dr. Richard Phillips explained. That is conditional recommendation since 2018 based on the CoLab trial in Bangladesh. And so we've been doing door-to-door case finding in highly endemic villages. And you see here an example of a village where every household is screened, and then in red you see the households with leprosy patients. And then if we draw a line of 100 meters around the houses, if more than 50% of the village is within a circle, then the entire village receives prophylaxis. And we tested this in EDCTP-funded people study, also in Madagascar. And Dr. Epco Hasker is presenting the final results of this trial next month at the Leprosy Research Initiative meeting. So here you see the preliminary results where we see a 41% reduction of the individual risk of leprosy. But this gradient here is where patients contacts are classified based on their distance to an index case. And you can see that the leprosy incidence remains higher in household contacts, so 4.2 after the intervention, down from 7.5 before the intervention. We also see a modest decline in the incidence at village level of about 40%, and this led us to test a stronger PEP formulation. So this is the study I'm presenting to you today is bedequalin 800 milligrams plus rifampicin 600 milligrams. And the control arm is rifampicin 600 milligrams as recommended by WHO. So we do active surveillance for adverse events, and everybody has EKG pre and post 24 hours later, and also liver function test screening pre and post 14 days later, and then they're seen again at 30 days. So the inclusion criteria are that you are in good health in a leprosy endemic village where the study was done, and children over 5 years and weighing more than 20 kilograms. And exclusion criteria are active signs of active leprosy or tuberculosis, any history of liver or kidney disease, any use of study drugs in the last 2 years or an allergy to those drugs. And for bedequalin specifically, the participants had to be able to swallow the 100 milligram tablets. And there was a list of safe medications. So if you were taking anything in the last 3 weeks not on that list, you could not participate. Anybody who was suspected to be pregnant or confirmed or breastfeeding was not eligible. And based on the baseline screen, if the corrected QT interval on the EKG was more than 450 milliseconds, or the ALT, AST more than 3 times the upper limit of normal, people were also not eligible. So this was a age de-escalation design where we started with the adults, and here you can see the numbers who were recruited. The main reasons for non-eligibility among the adults was pregnancy or breastfeeding, and among the children it was not weighing 20 kilograms. This shows you the results of the QTc measurements of both arms before and after study drug ingestion. So in pink the pre-treatment, and blue the post-treatment, and purple where they overlap. And at the top you see the children, then the adolescents, and then the adults. There was 1 out of 261 adults screened who had a QTc at baseline of 520 and who was not eligible for participation. And then if we look at the by study arm, you see that the mean QTc at baseline and then at 1 day, and the difference between the SDR-PEP control arm and the BPEP intervention arm. And you can see that in the adolescents there was statistically significant prolongation by 9 milliseconds that was not deemed clinically meaningful. And this is the results of the ALT pre and post-treatment by age group. If you look at the bottom, we started with the adults and we saw high baseline ALT to our surprise, and the internal quality control was okay, but then by external quality assurance, the lower range levels were falsely elevated, and this turned out to be related to a tube used in the lab for transfer of serum that contained an activator that interfered with the analysis. So when this was corrected in the adolescents and children, also the EQA for the lower range was correct. And then if we look by arm, there was no statistical difference between the ALT before and after between the control and intervention arm. So in summary, here you see all the adverse events and serious adverse events. There were 2 adults with serious AE that were not deemed to be related to the study drug. You can see that the drug-related adverse events were 57 in the BPEP and 43.6 in the control arm. And also for the adolescents, but not significant. These were the serious adverse events. So in the control arm, there was somebody with a diabetic metabolic decompensation 12 days after the study medication. And even though women of suspected pregnancy were not eligible, there was 1 woman who was pregnant at day 30, whose last menstrual period was 12 days before study ingestion. And she unfortunately had a stillbirth of twins who died in utero and had a knot. One of the twins had a knot in the umbilical cord, and this was unlikely to be related to the study medication. And this is a list of the main drug-related adverse events by preferred body terms and body system, and there are some increases in the intervention arm of dizziness, diarrhea, nausea, and headache, both in adults and in adolescents, more dizziness and more headache. And in conclusion, we say that bedaquiline 800 milligram single dose in combination with rifampicin 600 milligram is equally safe as rifampicin 600 milligram single dose alone. And next month, a phase 3 trial on efficacy of this regimen will start with the main outcome being the risk of leprosy. We also, because we're administering rifampicin and bedequalin to large numbers of people, we also monitor for drug resistance both the leprosy patients and the tuberculosis patients in the entire country. And we use a target deep sequencing assay for this. So the RPOB gene is what we focus on for rifampicin and the ATPE gene for bedequalin. And this assay has a limit of detection of 10% so that we can also detect the earliest signs of minority populations with mutations. But so far there's 0 rifampicin resistance, no, not even minority populations in the Comoros. So I rest to thank the participants, the DSMB and all the colleagues. This study is funded by Janssen as an investigator-initiated proposal. Thank you very much.
Thank you very much, Professor Bougui de Jong, for that very clear study using a single dose of bedaquiline together with a single dose of rifampicin for post-exposure prophylaxis for leprosy, and for showing that there were no significant concerns with the newer treatment. So it certainly will be interesting to see the results of the follow-up study when they're available, to see whether this combination of post-exposure prophylaxis does prove to be more effective than rifampicin alone. So thank you very much indeed. We're now going to have our next speaker, which is Dr. Kurt Reitmeier, and he's going to talk to us about cutaneous leishmaniasis, patient characteristics and treatment outcomes in Quetta, Pakistan, 2014 to 2021. Thank you. Kurt, the floor is yours.
Yeah, so on behalf of the team in Pakistan, I would like to give some highlights of a retrospective analysis of routine collected data of a large cohort of cutaneous leishmaniasis patients in Quetta, Pakistan. CL is highly endemic in Pakistan, and although between 17,000 and 27,000 cases are reported annually, the true incidence is estimated to be 3 to 4 times higher, in the range of 50 to 100,000. The most affected areas are KP province and Balochistan, especially the areas bordering Afghanistan, where Leishmania tropica is the main species. As you may know, CL will cause disfiguring wounds, debilitation, especially if the joints are affected, stigmatization and psychosocial suffering, especially in girls who are very worried that because of the stigma, they might not be able to find a suitable marriage partner. The standard of care in Pakistan is by pentavalent antimonal injections. But this treatment is very poorly available in the public health sector. And many patients, in that case, they revert to self-treatment, which may be treatment with nail polish or ink, or even more harmful things like battery acid or electrical burning, which is all non-effective, very harmful, and can leave very nasty scars. Since 2008, Médecins Sans Frontières, MSF, is supporting the Ministry of Health with free services for diagnosis and treatment of CL in Quetta, and since 2018 in Peshawar in the north. The graph on the right is not representing the incidence of the disease in Quetta, but rather the expansion of the MSF services, and especially also the increased community awareness of the free available services. Over the last couple of years, we are treating between 4,000 and 5,000 patients every year, with a small blip in 2020 when all outpatient services had to be closed for 6 months during the COVID pandemic. In the 3 treatment sites in Quetta, we have maintained patient line lists, which now include over 30,000 patients. And these have been analyzed. Diagnosis of CL is done by fine needle aspiration microscopy, but because of the imperfect sensitivity of this method, a dermatologist can also make a clinical diagnosis. Treatment is with meglumine antimoniate, with local intralesional injections if there are less than 4 lesions and smaller lesions, with 7 to 8 sessions over 3 to 4 weeks. But patients with larger lesions or multiple lesions or lesions that cannot be treated with interlesional injections, so near the eye, the nose, or the lips, they receive systemic intramuscular injections for 20 to 28 days. Treatment outcome is evaluated by assessing the re-epithelialization of ulcerated lesions, the flattening of non-ulcerated lesions, decreased induration, and absence of secondary infections. And in the photos on the bottom, you see a girl with a large ulcerating lesion on her cheek on day 0, with re-epithelialization at the end of treatment of day 28, and complete healing at day 70, but still leaving a permanent scar. In the analysis retrospective analysis of routinely collected data, we looked at patient characteristics, trends over time, treatment outcomes, and using several statistical tools, we looked at risk factors for treatment failure. Looking at outcome indicators, initial response or poor response were assessed at the end of treatment, and final cure or final failure at 6 months follow-up. By 2021, we had almost 23,000 patients with complete records and a recorded initial outcome at the end of treatment. And of those, 47% were female, with no significant difference between the various age groups. By far the majority of patients, so 63%, were children under the age of 15 years. Average age, median age of patients was 10 years, median duration of the lesions was 3 months, and the most affected body part was the face, affecting 56% of patients. Now, ideally, we would like to treat with intralesional injections because of the safety, but also that we know that it's more efficacious than systemic treatments. But over the years, we have seen an increase in the number of patients that required treatment with intramuscular injections from 12% in 2014 to 42% in 2021. Now, what we noticed was that male patients, they presented with larger lesions, and actually between 2014 and 2021, the proportion of male patients in the cohort increased from 40% to 57%. So this could account for at least part of the increased need for intramuscular injections. Then looking at outcome, poor initial response rate was 5.6% and final treatment failure 5.2% with 3% non-response and 2% relapse. Looking at factors that were associated with treatment failure was being female. An important one was age below 5 years, having facial lesions, or lesions smaller than 2 centimeters in diameter, which was very much associated with high parasitemia. We also found that 50% of the children under 5 they required extended treatment with intramuscular injections, so beyond 20 days. Now, the increased trend in patients requiring systemic treatment could be explained by more patients coming from further distances, coming with later stage lesions which were more severe and larger, but also more patients with lesions on the face. Slow responders were mainly young children below 5 years who required extended treatments compared to older age groups. Now, might be obvious that poor remote populations generally presented later with lesions requiring systemic treatment, and more wealthy patients with more nearby populations, they presented earlier with smaller lesions. Now, we hope that these are just a few highlights, but we hope that our findings can contribute to improving treatment algorithms and patient follow-up. So, yeah, what is clear is that a large proportion of patients require extended treatment to achieve initial cure, so longer than the WHO recommended duration of treatment. And especially young children, they show high rates of poor initial response and final failure. Targeted follow-up could be recommended after treatment, especially for patients with increased risk of failure. So especially young children, patients with facial lesions or small lesions with high parasite load. But we also need further research to get a better understanding of risk factors for failure. We suspect that we may be underdosing young children when treated with intramuscular injections, possibly due to the higher renal excretion rate of antimonials and therefore a lower exposure to the drug. But we also need to investigate alternative, effective, shorter and safer treatment modalities. I think it should be unacceptable that a cutaneous leishmaniasis, which is a skin disease which is not life-threatening, has to be treated with a toxic drug in long treatment courses with injections. Therefore we have to look in new treatment options. And until new chemical entities will come to the market, we have to see what we can do with the currently available anti-leishmanial drugs and also possible physical treatments. And in October last year, we started a randomized clinical trial evaluating the efficacy and safety of a combination therapy of 1 session of thermotherapy followed by 21 days of oral miltefosine. The same study is done by DNDi in New World leishmaniasis in Latin America, and we are doing this in Old World leishmaniasis, a special focus on Leishmania tropica. Another take-home message I would like to address is the possible impact of climate change on CL and other vector-borne diseases. You may be aware, last year was big in the news, the heavy rainfall and flooding in Pakistan, which is commonly attributed to climate change. The area of Quetta was mainly affected in August and September. And when the water receded, large amounts of waste and dirt and debris were remaining, and they are excellent breeding grounds for sandflies. And in a population where CL prevalence is already high, this can lead to increased transmission, and then after an incubation period of 4 to 6 months, increased incidence. And you can see that in the graph on the right, where several months after the flooding in December, there was a sharp increase in the number of patients presenting, which continued in the early months of this year with a tripling or quadrupling of patients presenting. which is challenging the treatment capacities that we have. And it's, yeah, if climate change will continue, we may see indeed a higher incidence of the disease in these areas. So I would like to acknowledge the MSF teams that have worked in Quetta over the years, but also the Ministry of Health, Medical Superintendent of Bolan Medical Center and Benazir Bhutto Hospital in Quetta. Thank you.
Thank you very much, Dr. Reitmeier, and for sharing your data on this really impressive patient data set. You've shown us that children that are young, less than 5 years of age, showed higher rates of poor initial healing and needed extended treatment times. And you also informed us that treatment failure was associated with facial lesions and also lesions with high parasite load. So this is very valuable clinical information highlighting the subgroups of patients that we need to take particular care with. But as you say, so much more is needed for our patients with cutaneous leishmaniasis. So thank you very much for sharing that with us today. We're next going to move on to our last talk of this half session, and I'd like to welcome Dr. Bonya Valentine Cognier, who is talking about basic infrastructure and essential component of integrated wound management. And this is sounding music to my ears, so I'm really looking forward to your talk, Dr. Cognier. The floor is yours.
Thank you, Michelle. Good afternoon, everyone. I'm Bonya Cognier. I'm sociologist, associate researcher at Centre Suisse de Recherche Scientifique in Côte d'Ivoire. Being part of the wound management project, I will say it's an honor for me to be here in person to present a basic infrastructure, an essential component of integrated wound management. To start with, I will briefly introduce the main component of our model. So the strategy of the project are based on two main components. The first one is all wounds count. Not only ulcerative skin NTDs, but also traumatic wounds, snake bite wounds, obstetric wounds, surgical wounds. The second one is identify and treat early with clear referral system between three levels: community, health center, and wound management unit at the district hospital. The aims of our project is to shift the management to early wound care in the community to prevent chronic complicated wounds. The strategy of our project started since 2019 and is still ongoing. The project has the following component. The first component is the on-site wound management repetitive training. The second component is the determination of wound burden and clinic epidemiology of wound with the combination of household and health service-based survey. And this is done repetitively. The third and the last component is the testing of our wound management model. We have 5 main project components in which I will present the basic infrastructure implementation and maintenance in detail. The 4 other components are wound care, wound burden and clinical epidemiology, socio-economical and psychosocial assessment, and impact and sustainability assessment. 2 components are published, and please have a look at our poster. A wide range of discipline sectors and institutions are involved in the implementation of the project. You can see epidemiology with One Health concept, the clinical hospital of Tabo, laboratory, sociology, and the health demographic surveillance system of Tabo. The project was implemented with equitable North-South partnership, Germany, Switzerland, and Côte d'Ivoire. Our project is carried out in Côte d'Ivoire, in the HGSS of Tabo, in a community of 4,200 inhabitants. The wound management unit at Tabo District Hospital was developed from a former Burulu RCR unit and is now serving all patients with complicated wounds. The objective of infrastructure component is to assess, implement, and monitor infrastructure requirement for wound management model at the rural community level. The key areas are water supply, potable water, wound cleansing, cleaning, toilets, digital and lab support, and the support of healthcare personnel. We base the infrastructure upgrading on a formal assessment. At the community level, minor wounds are regularly cleaned with soap and potable water after instruction by community health workers. At the health centers, where bigger or more advanced wounds are treated, wound showers have been installed. The infrastructure needs depend on the severity of wounds. To give you an impression of the wound category managed at the respective levels, I have included representative examples. You see here minor wound at the community level with community health workers, the advanced wounds at the health center, the severe cases at wound management unit at district hospital. A basic set of wound care material is sufficient for the management of most wounds: bandage, gloves, and local disinfectants. Locker for patient file for data confidentiality are also important. When we talk about basic infrastructure, water and sanitation play an important role. Water supply system, toilets, waste disposal. So digital support system make life a lot easier for diagnostic. To have clinical decision, to get expert advice to healthcare staff and patients, particularly in remote areas. In addition to that, we also have the data management. So in terms of main challenges, continuous supply of water. The first one is monitoring and maintenance of potable water quality. Water for hand washing and toilets. At the hygiene level, sustainability of regular cleaning of dressing rooms, monitoring, sterilization, microbiological assessment to be established. At the material supply level, the first challenge here is sustainability of pipeline for wound care material supply. sustainability of dressing box, potable wound care material for the community health workers, and maintenance and sustainability of waste disposal. So, wound management in resource-constrained countries needs basic infrastructure resources and well-trained and motivated community health workers. The approach to implement basic infrastructure for wound care is bottom-up and built with the communities and nurses. Community involvement is crucial for identifying affordable and sustainable solutions during the upgrading process and to sustain the wound management infrastructure. Infrastructure development fits into the universal health coverage strategy. In conclusion, our project covers 9 SDGs, here illustrated by pictures from our project. We work for people for whom agriculture is important. We support malnourished patients. The project is integrated in the health system. We invest in education and training. And the project is sensitive to gender equity. Water infrastructure are key. I already mentioned that in the presentation. Prevention measures are also important. The project reduces inequity. And also, good partnership is our strength. We will not be able to achieve all these objectives without the support of the community of HGSF of Tabo in Côte d'Ivoire, institutions and funders. Thank you so much for your attention.
Thank you very much, Dr. Kone, for the work that you've done and also the work of your wider team. You've certainly identified important infrastructure issues, particularly at the community and primary healthcare centre level. Yeah. You've also given us a basic structure of things to consider when we're trying to assess the infrastructure, so thank you for that. And importantly, in your wound management system, you have a clear referral pathway to the wound management centre at your local district hospital for the more serious problems. So thank you very much for that. We're doing extremely well for time. We've just, we're about 2 minutes ahead of schedule, I think, so I'm not doing badly today. We're going to open up the discussions, and whilst you're getting ready with your questions, may I just remind you, please, when you're asking a question, to say your name, quick identification of where you're from, and clearly say who your question is addressed to. Before we take answers from the floor or online, I'm going to take advantage of my position and ask Dr. Kone if he could explain to us the steps that he took to get water to that primary healthcare centre. Please, thank you.
Okay, thank you so much. So, in the frame of our project, when we arrived in Tabo HGSS, where we have the district of hospital, so this is where the health system was making the Buruli National, against Buruli National, the national program from health system were making the active phase. So our project is mainly in the rural area where they have the health center. And from the first assessment, we realized that they did not have water. So our strategy, and they were using the water from raining or maybe for sometime when they have to go to the river. So the strategy was to discuss with the local chief And with him and his community, and also in this area, they have a private sector who is in the banana farm to build together a water box in the health centers to manage this wound in the health center. Thanks.
Thank you very much. Now, we had some hands over this side of the room to start with. So, Wendy Megan, would you like to go? Thank you.
My question goes to Professor Phillips, and about the, especially on drug resistance and on leprosy. One of my concern is definitely on the rifampicin prophylaxis, now widely being administered, and we know that in the where we are working, screening the actual leprosy case and ruling out is a bit difficult, and so are we not developing selective resistance? And the other thing, or that's not going to be the future risk. And the other thing, I would like to get some idea about how are we diagnosing resistant leprosy? Because as far as we know, in the clinical setting, the guideline is if the patient is defaulter or if didn't respond, give him again, the same drug again and again. And we don't have really, at least our national guideline and the WHO, there is no really the treatment for resistant TB, and also how to identify resistant TB, leprosy. And the other thing is you have mentioned that rifampicin resistance is not a major public health issue. I'm just questioning this. Thank you.
Thank you. Who would like to answer that? Would you like to answer it, or Professor Phillips?
I think there are a lot of leprosy experts here. Would you like to comment on that?
Professor Boog de Jong.
Thank you for that very pertinent question. So at the time of the rollout of the WHO guidelines, the conditional recommendation, there was a consensus meeting that single-dose rifampicin with a half-life of 6 hours was unlikely to induce resistance, but there are very valid concerns that we shouldn't lose this important drug for TB and Buruli. So the resistance surveillance, what we do is, your question was how is it done? When we take a biopsy and we extract mycobacterial DNA, when the RLAB qPCR shows a low CT value, so under 26, then we have enough DNA for target deep sequencing, and this includes RPOB and other genes. So far, this high burden of leprosy on the Comoros cannot be explained by any drug resistance, because for none of the drugs, including fluoroquinolones, etc., have we seen any, even minority populations. So whether in that screen there were already some patients who had received post-exposure prophylaxis before developing leprosy, but fortunately their number is small, so it's too early to say whether rifampicin PEP does not elicit any drug resistance, but it's unlikely. And Dr. Phillips, in his overview, he explained what the guidelines are for when patients fail rifampicin-based MDT therapy, so then indeed other drugs are given. Thank you.
Thank you very much. We'll take a question over there from Michael Marks, and then from Vim, and then we'll go to an online question. Thank you.
My question's slightly along the same line, but I guess I'm very concerned about the use of single-dose bedaquiline, which has a very long half-life, and in which is now the single most important drug used in the treatment of MDR and XDR-TB, and is really transforming those regimes. And I guess I'm pretty concerned that widespread use of that is quite a risky thing to do. We know that it's incredibly hard to screen for TB. Symptom screens are unreliable, and many individuals have porcine disease, which will not be picked up even if you did sort of routine screening. So I guess, how confident are we that even if it shows some additional reduction in secondary leprosy cases, that is worth the widespread exposure to such a critical MDR, XTR, TB drug, when that condition is currently killing several 100,000 individuals a year?
I share your concern about bedaquiline resistance, and we are losing that important drug already in countries where it's used for tuberculosis. So the real long half-life is after the loading dose for 2 weeks. Even a single dose does have a much longer half-life than rifampicin. In the context of the Comoros, the 80 TB patients per year, there's 0 rifampicin resistance. And we will, over the course of the study, also screen all of them for minority populations. Does that prove that we are not selecting for resistance? No, but we will be able to detect the earliest signs of it.
Thank you. We're going to take a question from Vim, then we've got 2 online questions, then Professor Monkey, and then we'll go to that side of the room. So Vim next, please, and make your questions short, and just say clearly who you're addressing the question to, please. Thank you.
Thank you, Michelle. My name is Wim van Brakel, Medical Director at NLR. My comments are for Professor Phillips. He said that in the MDT regimen, indeed, there is some evidence of rifampicin resistance, but indeed that is not a matter of concern at the moment. There is a WHO-led global surveillance network for antimicrobial resistance, and so that is being monitored, although that is always open for improvement. It is true, however, that the current MDT drugs, notably dapsone and clofazimine, do have nasty side effects, let's put it like that, and therefore a shorter regimen, alternative regimen, is very desirable, especially one that would be usable for all types of patients and where intermittent administration could be used. I also would like to point out regarding the PEP regimen, the post-exposure prophylaxis, that there is indeed this conditional recommendation in formal WHO guidelines, and that in addition, large studies in 8 countries have shown that these conditions can be easily met and that refusal is very rare. There was a 1.7% refusal only on about 150,000 people who were administered PEP, and so both the feasibility and acceptability have been confirmed. However, an enhanced regimen is recommended, such as the one recommended or currently being tested by the group of Professor Bauke de Jong. Thank you.
Thank you very much. Now we've got a question online from Paulo Machado, and this is directed at Kurt, please. It's on the cutaneous leishmaniasis. He's got 2 questions, but I'll give you the first one first. Why are you using the IM route instead of IV? The volume of injection is very high, and IV administration is safe and better for the patients.
Main reason is logistical. With the large number of patients that we are treating, it's impossible to give a high-quality intravenous treatment, and with a higher risk of because it needs to be given by slow infusion, and that is undoable in a setting where there is a high patient load and limited number of staff.
Thank you. And the second question is about miltefosine. And do you indeed plan to use it in your area? And for the children with cutaneous leishmaniasis, can you offer miltefosine in an oral solution instead of capsules?
an oral solution does not exist of miltefosine. No, there is. You have there's a pediatric dose of 10 milligram miltefosine, and that is the lowest dose that can be given.
Thank you very much. Now, Professor Mokni, thank you.
Thank you very much, Chair. My question is for Dr. Kurt Reitmeier on cutaneous leishmaniasis. Thank you, Kurt, for this very large series, which is very informative. But I think, I don't know why, you give us only bad news. The people who not respond very well, who are the patient we are worried about, the female, the children, and with the facial lesions, and with a lot of parasites. That means we need alternative treatment because those category is the most important for us to treat. I have two small questions. It's quite surprising that the small lesions, there are the less responder. Is it because usually they are treated with intralesional, or it's resistance? What do you think? And the second question, the bad news also that there is a rise of systemic treatment. Also, why? Is it because there are complex leishmaniasis, or you think it's a problem of resistance? Thank you very much.
Yes, thank you, Professor Mokni. The first question was the small lesions. Yeah, that is a finding that we did, that especially lesions that were half a centimeter big, they tended to have a high parasite load and could easily be treated with intralesional injections, but showed a poor response. And the reason why that is, I don't know, we don't know. The second question was again on
the raise of the rate of systemic treatment.
Yeah. Now, I already gave one potential reason which will contribute is the increasing proportion of adult male patients over the years, from 40 to 57%. And male patients were generally presenting with larger lesions, and many of them requiring systemic treatment. But also with the increased community awareness of the program, the catchment area of the program extended to more rural areas where patients generally tended to seek health care at a later stage with larger and more complicated lesions. So those, I think, are the two most important reasons for the increase in intramuscular injections.
Thank you very much.
The interpreters kindly.
I can't see who it is. Could you just, right, you, sir. Yes.
Hi, my name is Dallas Smith. I'm from the Mycotic Diseases Branch at the U.S. Centers for Disease Control and Prevention. My question is for Barbara. I just wanted to say thank you for doing this analysis. I think this kind of reiterates what we've been thinking from access to antifungal perspective, and kind of going to some of the data you presented on the number or percentage of people who said they didn't have access, whether it's due to not having it on the ground or the cost. What did that percentage look like when you took out the high-income countries?
Go ahead, Barbara. Thank you.
Yeah, you were too fast, so I'm not sure I got all the question. But the issue of availability and affordability of medicines was raised across the whole spectrum of the respondents, because also respondents from high-income countries They mentioned that it was difficult to procure medicines, like in the US. And in Italy, there was one respondent also stating that it wasn't part of the national health insurance scheme because of the categorization of the disease. We had 25% of respondents from high-income countries. So obviously, as I said, we would need to do further investigation. But the finding of the survey indicate that the problem is not only for low-income countries or middle-income countries. It's also a problem of high-income countries. Also, one of the findings for eumycetoma is that 30% of respondents are still using ketoconazole. And in their comments, they indicated that ketoconazole and fluconazole are used because itraconazole is not available. And then posaconazole and voriconazole were among the most wanted medicines. But also for actinomycetomas, there were a number of medicines that were indicated as problematic to access. I hope I answered.
Thank you. Is there a Esther Kinyeru wishing to speak? Esther Kinyeru, you got a message?
Esther from Ministry of Health, Kenya. Professor Phillips, could you please comment on the minimally invasive methods like cryotherapy and thermotherapy? Then to Dr. Coat, do you see cases of cutaneous leishmaniasis recidivans? And what is your experience in terms of diagnosis, treatment, and the resistance rates? Thank you.
Can you please repeat which disease you are referring to?
Sorry, for cutaneous leishmaniasis.
All right, so what I said was that I looked at different options that people were using all over, and some were using IV, IM, and some doing intralesion. That's what I provided. And also the fact that liposomal amphotericin was also being used, but majority of people were using the pentavalent antimonials, and this is across different studies that have been carried around the world. So that's not what we are doing, but looked at what is available across the spectrum, yes.
Did you wish to add anything, Kurt?
Yeah, Leishmania recidivans, we definitely see it, especially in young children who have about a 6 times higher odds of developing Leishmania recidivans than older age groups. It is difficult to diagnose because parasitemia is very difficult to find in Leishmania recidivans, but the diagnosis is made clinically by the typical clinical presentation of the disease and the history of previous treatment for CL. But it is very difficult to treat and that's also one of the reasons of failures in young children is that it's difficult to treat the Leishmania recidivans.
Thank you. And your neighbour, go ahead, sir. Thank you.
Thank you. Santiago Nichols from Pan American Health Organization. First of all, my comment and question is for Dr. Kone. First of all, I really liked your presentation very, very much. Congratulations for the presentation and particularly for the work. I realized, and it was a positive impression for me that you mentioned your presentation was called Basic Infrastructure for Wound Management. So I suppose that when you talk about wound management, you cover the skin NTDs that cause wounds, but maybe other chronic diseases that also cause wounds. Is that the case? And that would be ideal because that is an example of integration of management of chronic morbidity between skin NTDs and other chronic diseases that can cause similar lesions?
Yes, that is the case. This is why we said all wounds count for us. Thanks.
Thank you very much. I'm going to wrap up the discussion now, and this is the moment you've all been waiting for, because I want you all to stand up now, and we're going to have a slight departure. So we're going to have a dance on the spot. Now, my mother used to be a ballroom dance teacher, so I'm going to do a sort of few steps of the cha-cha-cha on the spot, but I'd like each of you to do a dance on the spot that's relevant to your own culture, and I promise I will be looking, and I want to see the most flamboyant dance. So a few minutes, and then we will resume in a few moments. Thank you very much. Well done, everybody, and thank you to all our speakers.
Cool.
All right, everybody. Can I welcome you back into the main auditorium? Thank you. I don't want them to miss you. All right, everybody, thank you. We're going to start the second half of the afternoon, and I'm delighted to welcome my colleague, Dr. Hubert Vanya, from the World Alliance for Wound and Lymphedema Care and Geneva University Hospitals. And he's going to talk to us about the World Alliance Wound and Lymphedema Care Kit, a way to bring standardized basic dressing material for adapted modern wound care to low-resource settings. Thank you, Hubert.
Thank you very much, Michelle. Thank you for everyone for being here. And thank you for Dr. Kone to have opened this session. And you will see that my talk will interconnect with many aspects of what he has said. So the work, just in 2 words, important. I have no disclosures, no financial interest, but I wanted to sell you this book. There are a few hard copies here, but you can download it free from the website work.org. And I think it's a good book to have in your computer. So WORK stands for World Alliance for Wound and Lymphedema Care, and we created this small NGO in Geneva in 2009, following some of the Burley Ulcer meeting right here in WHO. And the idea was to improve the management of chronic wounds and lymphedema. Until we have medication to cure all these NTDs and all other wounds, we still have to do good wound care for our patients. So chronic wounds are still under-recognized in our treatments. They are seen as a comorbidity. There is no worldwide precise data, but we have a rough prevalence of 2 to 6%. Extrapolated to middle and low-income countries, that would mean between 70 to 210 million people affected by wounds in the world. And due to the increase in population, aging and diabetes, this number will rise dramatically. Often they are undertreated despite many improvements, both in knowledge and material that were developed these last 60 years. So we have developed a method for teaching, which is very important, teaching at grassroots level with 6 basic principles. The first one is to assess and correct wound etiological cause, and also other relevant diagnoses and states, like undernutrition, pain, HIV, for example. Then you have to maintain a moist wound environment in your wound. Wound healing is just biology. We are 70% of water. That's what needs a wound to be healed, in most cases. Then you have to protect your wound and all the surrounding skin from further trauma. We often see very small dressings that are dry, that will tear up the tissue when you take them off, and this is not very good for wound healing. Then we have to promote a clean wound bed and to control infection. This we all know, we have all learned to do this, but there are simple means, and for example, washing the wound with potable water in most cases, is very efficient, far more efficient than disinfection. We have to control the wound, peri-wound, limb, lymphedema, and edema. And that's very important because you have a lot of inflammatory mediators. You have a lot of macrophages, of proteases in the wound. And due to the compression that you can make, if you have access to what some called massage yesterday, but which is lymphatic drainage, in fact, your wound will be healing much better. And that's worse for nearly every wound, perhaps not the arterial ones. And then you have to prevent or treat physical sequelae and disability. You have seen all these pictures with very big wounds. If what you want is skin closure, you nearly always have skin closure. But if you have disability following this, it's not very functional, and your patient will not be integrated as easily if the wound is closed. And all this needs re-evaluation of each of these steps at the clinical side. If now we go to dressing material, well, we can see that it can play a key role in at least 5 of these basic principles, which are the following. And then this wound care kit, what is it? Well, it's designed to integrate standard NGO supplies. It's there to teach the basic wound care course that we can give. It can be offered to local health facilities, it can be given to colleagues going on mission for other purposes, but that will encounter wounds. It holds 26 items, around 16 kilos. It's a dressing material for about 100 to 400 dressings. The unit is 10 by 10 centimeters. It's easy to store and carry, simple to use. The products are stable, have long shelf life. They can be locally replenished or substituted. And they can be separated in order to be handed over to the patient for self-care. You will tell me what's inside. You have been waiting for quite a long time. So we have global hygiene products. We have soap and hydroalcoholic hand rub. This is the basic of hygiene. Then we have general wound care protocol, how to use the product inside. And we have specific wound care file. It's very important in order to follow your patient to have a file. And then we have very practical items like trash bag, shop box, pens. And what about dressings? Well, we have some disinfectant, but not too much. We have a little saline, but usually we rely on potable water. We have petroleum jelly gauze plus petroleum jelly in tubes. And then we have dry gauze, plenty of dry gauze. We have some silver sulfadiazine cream. We have elastic bandages, tape, transparent alimentary plastic film inside, which can be very useful to make dressing cheap. And you can see that all this can be substituted. Boiled water, shea butter, vegetable oil, clean cloths, banana leaves, honey, sugar, cloth, alimentary film for all of these basic products. We made an evaluation on about 40 of these kits that were distributed with colleagues. It's not always easy. We're not so much organized as MSF, for example, but others of you. But what we see, it's successfully used to treat, but also to teach, and that's very important. Users are satisfied with the content. It can be adapted to the local treatment plans and material, but dressing size should be revised. When you have a whole leg and only 10 by 10 gauzes, it's a bit difficult. Then you will see that there are unused items. For example, silver sulfadiazine was unused in many kits because people just didn't have the teaching on how to use it. Then for some instruments are missing. We based the kit on NGOs who already have instrument kits, but of course when you are in a health center, the instrument can be missing, and that's something to keep in mind. And then in some experience, we have seen that it can be enhanced by secondary, more modern dressings, such as alginate, hydrocellular foams, hydrogel, but which have a very higher cost. Just let me show you something. I was very happy to receive a gift last week. This is a 49-year-old lady. She has a post-traumatic ulcer on the leg, and she had no improvement in 2 months of dry dressing. And then she met a nurse who knew one of the physio who was giving the course with us, and this physio gave her some indication. So the lady will self-treat her, helped with the trained nurse, but advised by our physio. And after just 2 weeks, we have this nice granulation, just with water cleansing, petroleum jelly gauze, and partial occlusion with a plastic alimentary film, and a compression bandage. Bandage used not only to hold the dressing on the leg, but being from the toes to the knee. Hopla. So in conclusion and main challenges, we have to have chronic wounds to be recognized as a worldwide major concern. And modern adapted wound care, basic teaching should be done already at pregraduate level, nursing school, medical school, but also for all health caregivers. So recommendation for a basic standard material should be made and disseminated worldwide. Why do I have this picture? Why WHO has a list of essential medicine? Why not a list of essential bandages? And then don't forget the free book. And I would like to acknowledge, well, our patients, my fellow colleagues around the world. And when I mean colleagues, I don't mean only doctors, every health colleagues. And then especially Dr. Eric Comte, former member of Médecins Sans Frontières, based in Geneva, who led us through this concept. You know, during sharing a drink, he said, yeah, what don't we have a basic kit? And that's how we began the thing. And of course, the University Hospitals of Geneva Humanitarian Fund. Thank you very much.
Thank you, Hubert. This reminds us that for skin NTDs and for general skin conditions, the topic of treatments covers so much more than just drugs alone. I'm sure there'll be plenty of questions. Our next speaker is online, so I'm just going to find out if everything is set for the online. Yeah. So I'll carry on introducing our next speaker. Next is Herman Feldmayer, and the title of his talk is Control of Tungiasis Through Systematic Diagnosis and Treatment of Humans and Animals Using Dimethicone Oil in a Resource-Poor Nomadic Setting in Uganda. Professor Feldman, welcome, and you are free to start your talk when you're ready. Thank you.
Thank you very much. Good afternoon, dear colleagues present in person and present online. I only could join the meeting today due to health reasons. I recovered from a flu, and my voice is still a little bit weak, so I apologize if there are difficulties for the interpreters. I'm going to present, next please. Next please. I'm going to present you on behalf of, no, please, no, that was too rapid. No, back to the second slide. Yes, okay, thank you. As most of you know, Tungiasis is a zoonotic disease caused by the so-called sand flea, scientifically Tunga penetrans, and is endemic in all regions of Uganda. Even in the south, which has a tropical climate. Severe Tungiasis with more than 50 embedded sand fleas and secondary bacterial infection are frequent. People just in in an act of despair, tried to extract the embedded scent fleas using wholly inappropriate, non-sterile sharp objects such as safety pins and thorns, or they apply hazardous chemicals. And by this, they increase the risk of transmission of bacterial and viral pathogens, as well as of tissue necrosis caused by these hazardous chemicals. Although Tungiasis is listed among the 16 NTDs in Uganda, there is no control strategy in place. To cut a long story short, since decades, at least in Uganda, Tungiasis is totally neglected, and patients with Tungiasis are not cared for. Next. The study was carried out in Napak district in northeastern Uganda, a remote area not far away from the Kenyan border. There are no roads and there is no adequate infrastructure. People live in the so-called Manyatta. The photo on the right side, on the bottom, shows a small Manyatta with maybe 10 or 15 households. And the photo on the right side, on the top, shows a large Manyatta with up to 150 households. Next, please. Next, please. Yeah, thank you. The climate is arid with dry savanna and is populated by the Karamojong. The Karamojong are semi-nomadic pastoralists with subsistence crop agriculture, predominantly sorghum and sunflower. Next, please. Stop. Okay, then, okay. People live in very basically constructed huts made from, the walls are made from sticks and branches, and the roof is covered with bundles of straw. In each of these houses, between 6 and 8 people live. The floor is just beaten soil with many cracks and crevices, allowing that the off-host cycle of Tunga penetrans takes place inside. Since people are extremely poor, they sleep directly on the ground. Only a few have mats, and they cover themselves with rags. The small photo at the bottom, this structure is a kind of storehouse for grains, but as you can imagine, there are not many grains to be stored in such a small structure. And the photo to the right shows a house which has collapsed about a couple of months ago, but it was still inhabited by this family, the poorest of the poor, the mother, 3 children, and the grandmother. Every evening they crept into the collapsed house and stayed the night over there to protect them against wild animals. And if you have a closer look to the feet of the mother, the children, grandmother is already being treated, you will see that they are severely affected by Tungiasis. Even the small kids had more than 40 penetrated sand fleas at their feet. Next. The design of our project. Our project was designed as a community-based One Health intervention. In the first step, we recruited and trained local people, and we trained them, and they got the title, the Village Tungiasis Health Workers. In a second step, we did the census of the population, and then we started to do regular rounds door to door in each of the households of each of the Manyattas to diagnose and then immediately to treat people and animals with Tungiasis using NIDA. NIDA is a dimethicone, is a mixture of 2 dimethicone oils of very low viscosity, and we have shown previously in studies in Madagascar, in Kenya, and in Uganda that it is extremely effective and absolutely safe. Parallel to the door-to-door diagnosis and treatment rounds, we promoted community-based health. The data were collected using ODK tools and mobile devices. Not a single sheet of paper was used. Next. The census revealed that in the study area, 5,482 people were living, belonging to 1,335 households, with more females than males. Almost 50% of households kept at least one animal species, in descending order of frequency: cattle, sheep, goats, dogs, and a very few cats. A total of 15,501 animals were reported by the inhabitants, but more than 95% of the livestock was kept far away from manyatas because there were always the risk of cattle raising in the area. Cattle raiding in the area. Next, please. At the beginning, as well as at regular intervals, we performed promotion activities in the villages as well as at the schools. And as you can see from the photos, not only the children, but also the mothers very much liked the type of promotion activities our team had organized. Next. The overall prevalence of Tungiasis was 62.8%. 62.8%, the overall prevalence of Tungiasis. This is world record. The prevalence on the households is depicted here and is different for the three parishes. So in the parish Naitakwe, the lowest value was 32% prevalence, and in the parish Nangole Angolol, the prevalence per household was up to 100%. That is another world record. Next, please. The age-specific prevalence curve shows the typical S-shaped pattern. We know from previous studies in South America and in East Africa. The children 5 to 9 years old and the elderly people, elder than 60 years, had the highest disease burden. In the elderly people, the prevalence was even a little bit higher than in the small children, reaching up to 75%. That is the third sad world record, which was noted at baseline in Karamoja. Next, please. Here, the different columns indicate the prevalence after each round of systematic treatment. Altogether, there were 8 rounds of systematic treatment. So from the baseline value of 62.8% after the first round of treatment and diagnosis and treatment, prevalence turned down to about 44%, and after 5 rounds of treatment, it reached about 16%. During the 3 last round of treatments, the prevalence remained more or less the same, around a figure between 6 and 7. Next, please. Interestingly, the pattern of the decrease of intensity of Tungiasis measured by the median number of embedded sand fleas decreased very rapidly after the first round of treatment from a median of 11 down to a median of 6, remained for the next 4 rounds of treatment more or less at the same level, and then at the 3 last rounds of treatment it decreased a little bit further. Next, please. This figure shows the number of people who said they had an impairment of mobility due to Tungiasis. So at the beginning of the project, 464 people, children as well as adults, said their mobility was impaired due to tungiasis. And this number went down step by step, down to 5 at the end of the project. That means after 8 rounds of treatment in December 2022. Next, please. Even more importantly, the very severe cases, we call very severe cases those people who have more than 100 lesions. I can tell you this is really, this is even horrible. I had once two embedded sand fleas, and they cause a lot of pain. So if you have more than 100 lesions, you have pain the whole day, and you are totally immobilized. So interestingly, the number of people who were categorized as very severe cases went down from 96 at baseline to 0 in December 2022. Next slide, please. The very good news is that even extremely severe tungiasis can be treated, successfully treated and cured after treatment with NIDA, and this is shown by this series of photos. On the left is before treatment, after 4 days, then after 19 days, and after 27 days. If one has a closer look to the skin of the feet, all the inflammation has resolved and the skin looks already almost normal. To have this, to really cure patients with extremely severe tungiasis, you have to soak the whole feet in the dimethicone oil, and to repeat that a second time. In contrast, when there are only single lesions, 2 to 3 drops of the dimethicone oil are sufficient to kill the parasite and to stop the inflammation. Next, please. We were surprised that the frequency of tungiasis in animals was rather low. In all the maniatas, we only identified tungiasis in 56 animals. And over time, after the systematic round of treatments, no more infected animal was observed. How to explain this data? I think the important point is that the great majority of the animals were kept far away from the maniatas. And those animals which were brought into a maniata in the afternoon stayed there only for one night, and then the next day they went out for grazing again. So I would suppose there was little transmission of Tunga penetrans outside on the compound, and that the great majority of infections occurred inside. Next, please. Each household, or almost each household, regularly received friends and family members from outside the project area. From the perspective of transmission, this is a matter of concern. A great number of the visitors were infected, had tungiasis, and were infected with a large number of sand fleas, up to 50 sand fleas per visitor. So the visitors have to be considered a risk for reintroduction of tungiasis in this population, where with the regular rounds of diagnosis and treatment. We treated all the visitors, but we could not prevent that between the next round of treatment, there were other visitors, and the other visitors again brought tungiasis into the maniata or into the specific household. Next, please. So our conclusions are the following. In the extreme resource-poor setting, to frankly say, in 42 years of working in the tropics, I have never seen people living in such precarious conditions. The regular systematic treatment of Tungiasis in humans and animals with NIDA, combined with a certain improvement of body hygiene and environmental sanitation, reduced the prevalence of Tungiasis from 63% to 6%. Within a period of 2 years, that means after 8 rounds of systematic diagnosis and treatment. Mobility impairment due to Tungiasis was reduced to almost 0. Children could play, and the boys could play football if they liked. Very severe Tungiasis, more than 100 embedded scent fleas, had disappeared totally. And based on not yet published data, we suppose that ongoing transmission in the soil floor inside the houses explains why prevalence did not decrease below 6%. Thank you very much for your attention. Next slide, please. No? Yeah. Thank you very much for your attention.
Thank you very much, Professor Waldmeier, for this presentation and showing such good clinical results with really essentially a relatively simple and certainly very safe treatment. Can I just inquire, will you be able to stay on to the end of the afternoon sessions?
Yes.
And so you're able to take questions at the end? Thank you
Excellent.
very much.
Yes.
And if I don't get a chance later, we certainly wish you all a speedy recovery from your flu. Thank you very much for joining us, and thank you for staying on. We're going to move on to our next presenter now, which is Dr. Ruth Nyangacha, who is a senior research scientist at the Medical Research Institute in Nairobi. And her talk is entitled Secondary Bacterial Infections and Antibiotic Resistance among Tungiasis patients in Western Kenya. Thank you, Ruth.
Thank you, Michelle. Okay. Tungiasis is an extremely neglected ectoparasitosis. Even from judging just from the presentations that have gone on in the last 3 days in this room, we see that this disease is really the face of neglect, even among the neglected tropical diseases community. And so we need to do a bit more so that we can be able to help the community that really needs our help, that is suffering in silence. This disease is caused by the female flea, Tunga penetrans, and to a lesser extent, Tunga trimamillata. It occurs in any part of the body that comes in contact with contaminated soils, and this is contamination with the infecting flea, Tunga penetrans. And death has been reported in severe cases due to secondary bacterial infections. This is the life cycle of the infecting flea Tunga penetrans. I thought I would say a little bit here because I know that the disease is not very well known. And the life cycle kicks off when the female flea expels eggs into the environment. And it does this over a span of like 2 weeks. And it lays a lot of eggs, like between 100 and 200 eggs into the environment. And these eggs hatch into larvae. Then the larvae form pupa. And from pupa, the adult hatches and looks for a suitable host. This could be an animal or human beings. And then the animals, in this case, then act as reservoirs. Like in the case of Brazil, dogs have been reported as reservoirs to this infection. And then, of course, when the flea seeks a suitable host, like in the human beings, and penetrates the skin and embeds in the top strata of the skin, epidermis, then essentially the life cycle is completed. Now, secondary bacterial infection is quite common in endemic communities. We find that initially it was only suspected by clinicians in endemic communities that there was something going on with the lesions of this caused by this flea. And they described the characteristic symptoms of secondary bacterial infection. But it wasn't until in 2002 when a team led by Feldmeyer was able to systematically investigate this phenomenon and confirm that actually the lesions were infected by something else other than the Tunga penetrans, and these were bacterial infections. And so this flea is very interesting in that when it penetrates the skin, it actually leaves a tiny opening in the skin that is around 250 to 500 micrometer, through which it is able to expel the eggs, it's able to take in oxygen, and it's able to breathe through this opening in the skin. And so it compromises the integrity of the skin to protect the individual. And as it does it, it's also continually feeding, sucking blood from the individual. And so we find that the outer surface of the skin is actually connected to the bloodstream, and this is how the bacteria gets in. And so in severe cases, untreated tungiasis is a risk factor in acquiring bloodstream bacterial infections. For purposes of this meeting, I will only present on 2 specific objectives, but these objectives were part of a bigger research project that seek to provide epidemiological and clinical data on tungiasis that will support community-based and public health control measures. These 2 specific objectives are, 1, to identify bacterial pathogens associated with secondary infections in tungiasis patients in Western Kenya, and to establish the antimicrobial susceptibility profiles of the most common bacteria isolated. And this is how the mother research project looked like. And for objective 1, we were able to determine the prevalence and risk factors in the area, and this work was published in 2019 in the PLOS journal. And we were also able to identify the infecting flea as Tunga penetrans. For objective 3 and 4, which is identification of bacterial pathogens and their antimicrobial susceptibility profiles, is what I'm going to talk about. And so the study site is in Western Kenya, in a county called Vihiga. Participants were recruited by the help of community health workers. Then swabs were taken from lesions, which clinically showed signs of secondary infections, and these were like swelling, erythema, and pus formation. And this was done after disinfection of the surrounding skin with 70% alcohol for 1 minute. Then the swabs were taken to the Cambridge labs for identification of the suspected bacteria colonies, and this was done by colony morphology, gram staining, biochemical tests, among others. The Kirby-Bauer disk diffusion test was used to determine the drug susceptibility profiles. This study was approved by the Cambridge Scientific and Ethics Review Unit, and informed written consent was obtained from participants. Now, at the end of the study, we were able to treat participants according to the national policy guidelines by bathing the affected area with 0.05% potassium permanganate for 10 minutes. And for severe cases, we referred them to the facilities through a referral system that the community health workers have. But recently, we were able, through a study that was done in 2014, it was determined that this potassium permanganate is really not that effective to around 40%. It has around 40% efficacy, but ethically, that is what we had, and that is what we were able to give the participants. On top of that, for participants who had fewer lesions, then the flea was surgically removed under sterile conditions. A study nurse vaccinated the participants against tetanus. And these were the results. We were able to isolate 10 strains of bacteria, with the highest bacteria isolated being Staphylococcus epidermidis. Now, Staphylococcus species were thought to be actually, bacteria that is found in the skin, on the skin surface. And so they were initially thought to be harmless commensals. But we know that once they get into the bloodstream, then they cause serious infections that could be life-threatening, and in some cases even could be fatal. Out of the 10 strains of bacteria, 8 were gram-negative. For the antibiotic susceptibility tests of gram-negative bacteria, out of a possible 11 drugs that were tested, the bacteria was sensitive to 6 of them. And this is ciprofloxacin, ceftotaxime, norfloxacin, gentamicin, naldicic acid, and chloramphenicol. Then they were resistant to 5 of these drugs. Ampicillin showed the highest resistance to seen with ampicillin. For the gram-positive bacteria, we were able to isolate methicillin-resistant Staphylococcus aureus. We know that, known as MRSA, we know that MRSA is known to be multi-drug resistant, and this was true also for this study. We saw it being resistant to more than 4 other drugs. But the good news is that it was also sensitive to 4 drugs, which is norfloxacin, ofloxacin, meropenem, and gentamicin. After the bad news, the good news is that all the bacteria isolated were actually sensitive to gentamicin and norfloxacin, which are broad-spectrum drugs. In conclusion, the study confirmed the presence of multi-drug-resistant bacteria in Tungiasis lesions. The treatment regimen for Tungiasis, especially in severe cases, should be expanded to include antibiotics. And where sepsis is observed, a broad-spectrum drug like norfloxacin and gentamicin may be considered at the onset to avoid delay in starting treatment, as results from cultures are awaited. This work was published in the PLOS Neglected Tropical Diseases in 2019, and I wish to acknowledge the team behind this work. The names are listed there. I also want to thank the WHO for allowing me to present this work, and also for facilitating me to come and present the work here on behalf of the team, and the county government and community in Vihiga County, my colleagues at the Kenya Medical Research Institute and the University of Nairobi, and the Kenyan government for funding this work. Thank you.
Thank you, Ruth. That was very clear, and I'm sure it will generate a lot of discussion. Now we come to our last presentation of the afternoon by Professor Christian Johnson. And I think everyone knows Professor Johnson. He's a medical director at the Raoul Fallaro Foundation in Paris, and his talk will be in French, and the slides are in French, but obviously there is translation. The talk is entitled Beta-lactam-containing regimen for the shortening of Borreliosa disease therapy, Phase 2 in Benin, clinical trial update. Professor Johnson, the floor is yours.
Merci beaucoup.
Thank you very much, Chair. as I am the last presentation, but it's last but not least. So I would, if we could have the next slide, there we are. I would like to share with you, that's not the right slide, I'll continue. I'd like to share with you the stage in the phase 2 clinical trial in Benin for the shortening of treatment of Buruli ulcers in Benin. I'm not going to concentrate on what the Buruli ulcer is. You all are aware of it. Right. So we are all aware of the standard treatment which was recommended by the WHO, which consists on a daily antibiotherapy of rifampicin and clarithromycin orally for 8 weeks. And sometimes this needs hospitalization of the patient for the entire treatment. And that, of course, is not always very good, but if we can reduce the duration of treatment, it is good for the healthcare system, but also for the patient. So what we did was, having looked at this situation, if we could have that slide, please, yes. Preliminary studies showed that we can have a synergetic effect of the association of amoxicillin and the clav product combined with rifampicin and clarithromycin on the ulcerants. So that means that it can be given orally that is suitable for the treatment of adults and children, and it's a medicine that's available in countries. So bearing in mind all of these points, we decided to work on a clinical trial where we would evaluate the potential for reducing the treatment of Buruli ulcer from 8 to 4 weeks through the co-administration of amoxicillin and clavulanic acid along with the existing treatment recommended. So what we were going to do was to look at the proportion of patients with a full healing and with no recurrence of lesions and no surgical excisions within the 12 months. And so we looked at various sites in Benin. We had 3 for treatment and diagnosis in Alada, Lalo, and Pobe. These are 3 reference centers that take charge of leprosy patients as well as those with Buruli ulcers. And this is all part of the national program against leprosy and Buruli ulcers. So this was held as a open, multi-centered, non-inferiority, randomized and controlled trial of phase 2 with 2 parallel groups. And so all new cases of Buruli ulcer that were diagnosed on the basis of the clinic, on the clinical basis, were accepted to participate in the study. And as we do in our program, we try to remain as close as possible to what we're doing in the field. The patients are divided into 3 groups, which are categories 1 and 2, which are the reference, and 3, which includes those who have the greatest and largest lesions. And so we had 140 patients that met the criteria for inclusion at a power of 80% and then 186 at a power of 90%. So this is how we organized the sorting of the patients. So we had a testing which could be passive or active, and we then moved the patients through it based on the World Health Organization scoring which helped us to class them as very probable or probable biliary ulcer patients, and we used the evaluation score. And we chose those who were in the probable and very probable categories. So then we ensured that we had informed consent signed and that we went through this. So those patients who didn't meet the criteria were given the normal treatment, and those who did meet the criteria for inclusion were classed into categories 1, 2, and 3 and then randomized. And through the process, depending on which arm of the trial they fell under, they would have either the RC8 treatment or the RCA4 treatment, which would last 4 weeks. And then we would confirm this by PCR testing. And we carried out treatment visits at week 0, 4, 6, and till we got through to the end. So where are we with this clinical trial? Until now, we have found 59 patients, and 50 have been included in the study, and they were listed and scored as probable or highly probable for BU in the WHO scoring. 9 patients were excluded because they were seropositive for HIV, they had bone lesions, or they were below the age of 5 or above the age of 70, so they were excluded. We have 56% of the patients who were below the age of 15. And if we look at the WHO score, we had 60% who fell in the very probable or very likely score. And in the 4-week arm of trial, we had 52% and 48% in the classic trial. So what can we say of these 50? I have 30 that are highly probable and 20 that are probable. And of the 30 that are classified very probable, we had 93% that were PCR positive, and in the probable category, we had 65% that were positive with PCR. So here are some of the details of the patients set out by categories, category 1, 2, and 3, and following which randomized arm of the trial they were under. So how did the clinical trial take place? When it came in terms of, if we compare it in terms of expected and actual recruitment, for now we just have 35.7% of our objective at the 80%. We carried out screening and testing in villages where there were notifications of a lot of cases. Well, we're having fewer and fewer patients. It's not necessarily good for the clinical trial, but I think it's good for the population in general. We documented all the adverse events. And what are those that we came across? Well, we had 6 in Pobe, 5 in Lalo, and 4 in Alada. So we have minor adverse events, which were not necessarily affecting the treatment. We had severe anemia, hypertension, or patients with pain. And among the 5 in Lalo, we had high bilirubin levels, hyperproteinemia. We had someone who had a domestic accident and broke a leg, and then we also had some who had malaria or dermatitis. We also had some with slightly raised QTC, where we asked for support from cardiologists and everything returned to normal. We also had some with headaches, really minor adverse events that were taking place, and they didn't stop the treatment course. We also had gaps from the protocol where we had patients who we had a patient who presented very developed lesions, and at the 6th week it was already scarring well and healing well. So we had people who were able to catch up with them later because they were not necessarily available for all visits. And some who were under the arm, we saw that they had healed well, but then they left for Nigeria, and we lost contact with them. But most of them we caught up with. So what we found in terms of difficulties within this trial was, one, is that as in many countries during the pandemic, we had a lack of stock and supply of some specific medicines, but we were able to obtain drugs later. But we had more difficulty in recruiting as we had expected to recruit because there was a diminution of observed cases in recent years. But we have been assured that we will soon have all the medicines, and we'd like to thank those who are helping us. But we're going to strengthen our active strategy to find patients for recruitment to the trial. So what is the follow-up going to be to this? We carried this out to phase 2 in Benin, and we're going to spread this to a phase 3, where we will include Togo, Côte d'Ivoire, and Ghana. Togo has started with the effective recruitment of cases, the first 2, and from April we will have recruitment of cases for Côte d'Ivoire, and then we hope to follow on with Ghana. So we've started phase 2 in Benin, but we're going to move to phase 3 in Ghana, Côte d'Ivoire, and Togo. So should this be successful, we will be working on really diminishing the length of treatment, which is very helpful for patients, because it's not easy to take medicines daily for 8 weeks. So I would like to thank all those individuals and institutions that have helped with us. Next slide, please. So we have a team involving various institutions in Benin, in Togo, in Côte d'Ivoire, in Spain, in Ghana, and I'd also like to thank GSK and Tekol Foundation for all their help, the World Health Organization, so many institutions that have participated in these trials and that will help us not only to improve the level of treatment in countries, but also to provide information and evidence that will help us improve the treatment for patients. So thank you very much for listening. And I think we recently sent an updated version which links to the website for the clinical trial. So we have a website which has been prepared for this clinical trial, and we'll make sure you all have the links so that you can look and see the information that's available there. Thank you.
Thank you, Dr. Johnson, and for the work that's really taking us closer, hopefully, to a shorter treatment regime for borreliosa. Now, the floor is open for questions, and I'm going to cast my eyes to this side of the room first, and then we have an online question. So, if we could start with you, please. Yes.
Merci beaucoup.
I'd like to thank Dr. Johnson for this presentation. It was very interested. We're always pleased to learn about innovative ideas. Now, in terms of the protocol, I was wondering, why didn't you look at it the other way around? So first of all, you take data on the lesions, and then you look at which occur most frequently, and then carry out the clinical trial. Because if the ulcer has been complicated with a fungal infection, you don't know if it's the medicines, the antibiotics, that slows or accelerates the healing. So even if it were to work, one won't know what could lead to being able to deal with the healing. I'm just asking the question. I'm wondering if that was something that you considered.
I'm going to ask if there's a short answer, and if not, you could maybe answer more fully outside. But just in general, if you can keep your questions short, but if you'd like to respond briefly, Dr. Johnson.
Yes, in this trial, we want it to be as close as possible to what already occurs in the field. Of course, in the field, the patients aren't recruited from the laboratory confirmation. They are recruited on the WHO clinical score and the confirmation of the tests that are taken, the samples that are taken. So we want it to be as close to what happens in the field so that our conclusions could be as transposable as possible to the reality of the situation. Thank you.
Thank you. Now, anyone else on this side of the room? Yes, in the middle, sir. Please be brief.
Good afternoon. I'm Dr. Tucker from Liberia. My question is directed to Dr. Hubert Fognat. I hope I got the name right. If not, I apologize. I'd like to appreciate your work on the wound care kit. I think it's very helpful in resource-poor countries like where I come from. I just am interested also in the fact that it has a guide. I would like to know whether within the guide there's some classification of wounds to ensure that certain sort of wounds, like highly infected wounds or wounds that are not properly perfused, are referred to appropriate facility to prevent health worker or maybe a community health worker or using these kits and keeping a patient there for a longer period of time without getting results. I also want to find out whether the intent of these kits is that it can land in the hand of community health workers who will have limited health training, or should be restricted to, for example, mid-level health workers like nurses. Thank you very much.
Thank you. And my name was quite correctly spelled. So the first question was for wounds that wouldn't close. As I said, this kit is mainly used with trained persons. So training is about 5 to 10 days, depending on the opportunity we have. And during the training, we try to sort which are the most complex wounds and which should have recourse to dermatologists, surgeons, and so on. What we see also is that not all communities can go to such facilities, but we try to do it. And then in which hand do we hand the kit? Well, it's so simple that with some explanation it can get really in the field to health workers. And we have colleagues, nurses, who extrapolated this in the northern part of Benin in very poor communities, and they transformed the gauze into cloths and boiled water and so on, and trained the community to use it directly in the community. And I don't know if it answers the things well. And then we also use some training So we train the health caregivers to train the patient to do self-care.
Thank you, Hubert. We have a question from one of the online audience, and it's actually for our online speaker. Is that going to be feasible, please? This is a question for you, Professor Veldmeyer. There's just an inquiry. Do you have any information about the current state of the villages now? Is the Tungiasis still under control, or has it all come back? And may I ask a question of my own? Can you just clarify, did you have to make up the 2 oils yourself, or was it already made up?
Then I start with your question. You mean the OKD tool for collecting the data via mobile phone? No, we had an IT technician, and she prepared all the tools.
No, the NIDA, the NIDA oil. The NIDA.
The NIDA oil. The NIDA is a commercially available dimethicone oil. So it's sold. It's commercialized all over in the world as a medical device against head lice.
Yes, and that was the actual product you used.
Yeah, exactly. And so concerning the dynamics of what happened in the villages after the first phase of the project came to an end, is that slowly by slowly the prevalence and the intensity start to increase again. And we are now in the phase now in the preparation of a second phase of this project, where we want to implement the existing knowledge and the existing capacity by the village Tungiasis health work. We want to implement that in the schools. So there is no medical infrastructure at all. There are no primary healthcare centers. So we will transfer everything, knowledge, diagnosis, treatment, and prevention to the schools. And we want to reach not only pupils which are in school, mothers with smaller children and adults who want to be treated against Tungiasis, they can come to the school. So that project will start from May, and is projected for another 2 years.
Thank you very much, and thank you again for staying online. We have a question in the room, and it's Dr. Tim Stenier. Are you ready? Thank you.
Yes, thank you. My question
is for Professor Johnson. I'm going to try and ask it in French. So, if it doesn't work, I'll switch. My question is, are you going to test the intestinal microbiome in the patients? Because the antibiotic regime could be quite hard. We know that the microbiome is extremely important for health overall. Yes, in this trial, we have a pharmacocinetic plan, but we haven't yet done that, so maybe we should discuss that in the future.
Thank you. Anyone? Sorry, yes, thank you. Go ahead, Professor Mockney.
Thank you very much, Chair. I have 2 small questions. The first one for Dr. Hubert Viogna about the kids. Thank you very much for your important kids, and thank you for including the compression bands. But how do you the challenging problem? How you solve the challenging problem that the wound care is long for many weeks, and it demands a lot of, I think, many bandages and many kits. How do you challenge this situation, because it's weeks of treatment? My second question is for Dr. Ruth Nyangasha. I think we should, Tungiasis, it's a sort of small ulcer, we should treat by antibiotic only when there are clinical infection, because most of the bacterial we had in the swab are colonization, it's not infection. Thank you very much.
Thank you. I've just heard that we are allowed to keep going, so any more questions? Yes, Lynn, over this side, thank you.
I just wanted to make a comment on, obviously, Dr. Feldmeyer's talk, because he mentioned, I mean, there's this fabulous product, NTD, which he demonstrated its efficacy and it's safe, but he said it's available globally. It's not. It's patented and registered in the developed world for head lice. And there's no patent and no registration in Tungiasis endemic countries. And so I know WHO knows this. We're hoping to work together to move on this because it's a product that we desperately need in Tungiasis endemic areas.
Thank you. And there was a question behind. Yes, go ahead, please.
Merci.
Thank you. I'm Dr. Bernard Bois from the Central African Republic, and I'm interested in asking a question of Professor Feldmeyer on Tonga. First of all, I'd like to congratulate him on the relevance of his presentation. It was very good to see, because when we work in the field and look at NTDs, in particular skin NTDs, we see many cases of Tungiasis. But when people come and ask us what should be done, how do we treat this, we often try and have a low profile because we're not really sure what to do with it. But here in the presentation, we were shown that there is treatment, the NTD, and so I'd like to know if NTD can be found in our countries, or if not, or whether it's possible to be given the chemical name, because it could be sold under another name, it could be another name, and be available in our countries. And also if we could come back to the practical applications, or is it 1 to 2 days? How many days of application to have good results? So that's my question for Professor Feldmeyer. Thank you.
Go ahead. Thank you.
Si vous voulez, je peux répondre.
Oh, I can answer in French if you like, dear colleague. As you were able to observe in your country, there are many patients and villages that have up to 50% of infected population. When we come to the medicine, in English, I'm switching to English.
It's not called a medical device because the action is purely physical. There is no pharmacological action at all. So it's registered in many countries of the world, unfortunately not yet in Africa, as a medical device. And it is composed from 2 dimethicone oils, synthetic oils, which have a very specific low viscosity. A very low viscosity oil transports the higher viscosity oil into what we call the abdominal cone. The abdominal cone is a kind of Achilles heel, a target, because in this abdominal cone, in an opening of about 50 micrometers, the tracheal system of the parasite begins, the genital tract begins and ends, and the intestinal tract ends. And the NIDA, this mixture of the 2 dimethicone oils, blocks oxygen supply, blocks the genital tract, so no more eggs are excreted, and blocks the intestinal tract, which eventually leads to a rupture of the intestine.
Thank you very much, Professor Feldman. We are out of time. I would like to thank all of the speakers for this afternoon's sessions. And thank you for all of your questions. And well done. Thank you so much, everyone.
All right. Okay. Yeah, thank you very much, everyone. It's been another wonderful day. We would like to congratulate the speakers again. Can we give them another applause, please? So we've come to the end of today. A few announcements before we leave. There is going to be a meeting on Borrelios treatment, current and future landscape. This will take place in this room after we have all finished. There's also another meeting planned on fungal NTDs, global surveillance. Invitation, everyone interested. It will be upstairs, room U1. I think, and then there are other side meetings that I've already announced. For everyone for tomorrow, we have been informed that the Director General will be here at 9 o'clock because he is traveling later, so he cannot come at the end of tomorrow's session as originally planned in the agenda. So we'll get the key messages we would like him to hear before he leaves, and then at the end of the meeting, we will have our own conclusions, recommendations that will go to the director of the NTD. So if anybody has, and I've already asked all of you, any big ask for the Director General, send them to us. We're going to compile them tonight for presentation tomorrow morning. Kindly try to be here about 8:30 if possible, so that he can start at 9 and then leave for the airport. Please make time tomorrow to come early. I don't think we have any other announcements. We have received all the photographs taken on Monday and Tuesday by the photographer from Anesvad Foundation. They are on WeTransfer. Stephanie will send to all participants tonight, in person and online. Please download them immediately because they will, the link will expire in 5-6 days' time. So I'm reminding you, as soon as you receive this in your email, download all, and then you can choose and select any one of them that you like to use. Thank you very much, and please be back tomorrow, 8:30. Thank you.
Hello, everyone. Hello. Hello, everyone. Is it working? We are having a side meeting now, so the ones that are interested, please keep in the room. Otherwise, it would be good if you could continue your conversation outside the room. Please, we are going to be starting the same meeting.
Excuse me. Excuse me.
Ils ont coupé en fait. Stéphanie, ça ne marche pas.
We'd like to request everyone to leave this room because there's another meeting happening.
Votre attention, s'il vous plaît.
Hello? We'd like to request everyone to leave the room except the participants of the upcoming meeting. Thank you. There's another meeting happening now, so those who are not participating in that meeting, can you please leave the room for the meeting? Thank you.
Hello?
Hello, everyone. Can you hear me? Okay. It just works. It's here. Yeah. Okay. Thank you, everyone, for attending this design meeting. My name is Santiago Ramon from the University of Zaragoza in Spain, and I have Christian Johnson in here as well that just presented the beta-lactam trial that he's going to be moderating the session. So the agenda is, you can see it there. So I'm going to do first an introduction of the current clinical trials that are ongoing for Buruli ulcer. Then Dr. Jer Plusky here, he is going to give updates on Telasevec, the new drug, be very effective and potent against ulcerans. And then Dr. Paul Johnson, that I don't see him, or okay, he's there, perfect. He's going to give us a vision of Buruli ulcer in Australia, and finally we move into a general discussion moderated by Professor Johnson. So just a short introduction on the treatments. We all know that before 2004 there was no surgery, only was surgery an option, so no treatment for Buruli ulcer. And in 2004 we started having treatments with rifampicin and streptomycin. And then in 2017, WHO recommended an all-oral therapy with clarithromycin and rifampicin for 8 weeks. Actually, here we have lots of people working in that in that trial. But what is clear for all of us is that compliance is challenging, and actually WHO, one of the priorities is for research is to reduce the treatment. So make it in shorter than just 8 weeks. But here we are facing a problem. I mean, it's good for the good for patients, a problem for developing new treatments, which is declining numbers on Buruli ulcer incidence. And another interesting thing is that the dynamics of the disease are different in Africa and in Australia. So in Africa, it's generally more than 50% of the patients are under 15 years old, and in Australia is over 60 years old. And all this integrates a different complexity and a different dynamics in how we approach the disease. So, look, okay. Up until now, I mean, developing a drug for a very neglected disease is you don't have the pharmaceutical companies behind, and it's difficult to get funding and to get money for this. And mostly has been investigator-driven. And actually, this is effective, and it's a way of making this easier and more affordable. But now we are reaching a point in which we should consider that when we run a clinical trial, it's actually very efficient and sustainable, especially due to the lack of funding and then to the difficulties on running these trials. So as a community, we need to actually think and consider what is going to be next useful in next trial. So, with the projects and also this thinking that it's very difficult to develop a new drug for this neglected disease, we actually approach this from a drug repurposing perspective. You know, this is, I'm showing here the timeline of developing a new drug from the discovery, preclinical development, then you go into the clinical trials, et cetera, et cetera. And the parts that are fading are the ones that with a drug repurposing approach, they could actually be in skip. So if we identified a drug that is already in the clinic and we have safety packets, information, etc., we can jump quickly into clinical trials. And in doing this, in considering repurposing, there was a focus on rifampicin. Rifampicin is the cornerstone drug for tuberculosis, but also for Buruli ulcer, and has a very important quality that is both bactericidal and sterilizing. And actually, there is a relation with the dose and the efficacy. So if we could improve the activity of rifampicin, we could improve the efficacy of the therapy and actually reduce the treatment. So there have been, with rifampicin, there have been two approaches. The first one is to actually do what's called a high-RIF strategy. This has been extensively explored in tuberculosis field. Actually, already in 1978, there was Jacques Rosset, who's one of the fathers of tuberculosis research, actually describing that rifampicin had this sterilizing activity. And in 2011, already it was being questioned the dose that is used for tuberculosis and rifampicin, 600 milligrams. Have to consider that rifampicin was developed, introduced in the 60s, 70s, and it was very expensive at the time. So this dose was actually considered to save money, so that you could treat more patients. But it was not actually optimized for efficacy. So lots of different studies and works in vivo and in vitro, and also from the Panacea Consortium for tuberculosis, there were lots of studies showing that actually the dose of rifampicin could be increased without compromising safety. And it was shown that right now we are using 10 milligrams per kilogram. It was shown that it is safe to use up to 35 milligrams per kilogram, okay? And another interesting work that actually come from modeling is that now rifampicin is dosed based on a weight band, but actually a flat dosing could be as efficient, which could simplify actually the treatment when using rifampicin. Now, moving from tuberculosis to Buruli ulcer, there has been studies from people, Paul, I think is somewhere around here, there you go, showing that actually high-dose rifamycins in mouse models can actually shorten and are more efficacious the treatment of Buruli ulcer. And they were studying not only rifampicin, but also rifapentin, another derivative with an extended half-life that could also make easier the dosing. So, second approach, synergy with rifampicin. So we can keep the same dose, but make rifampicin more potent. And this is work also coming from tuberculosis, we identified that beta-lactams in general, they have a very strong synergistic interaction with rifampicin. What you see here is a time kill assay. The black line is the normal growth. The blue is, in this case, cephradine, a cephalosporin, and the red is rifampicin, and then you see the purple is the combination. The combination really kills everything and actually sterilizes the culture. So we moved this into Buruli ulcer, Mycobacterium ulcerans, and this work was actually presented 4 years ago. And what we found is that with amoxicillin, there is a very, very strong synergistic interaction with rifampicin. This is a checkerboard assay. The blue means growth inhibition, pink means growth, and that staircase-like shape that you see means that we can actually reduce the dose of both of the drugs. And we can actually see that in, time kill assays as well. So what we see is that for this strain, for example, R plus C, which is rifampicin clarithromycin, has no interaction. But if you include AV, which is amoxicillin clavulanate, in combination with RIF or RIF plus clarithromycin, it has actually a very, very strong synergistic interaction at killing. So with all this, we decided to focus on amoxicillin clavulanate because of the strong synergy, but also because it's the most widely used antibiotic in the history of antibiotic therapy. There is a lot of safety information. It's been used, it's safe, can be used for children, oral, etc. And for this, there was one question, right? Is that what is the dosing that you are going to use of amoxicillin clavulanate? Typically, the driver, the pharmacodynamic driver of amoxicillin clavulanate is time over the MIC. And it's administered 3 times a day. But actually, in our trial, we cannot do RIF 1 day, clarithromycin 2 days, amoxicillin clavulanate 3 times a day. That would be very not practical for actually administering. So we actually explored if we could match with clarithromycin only, with the taking of clarithromycin twice a day. So here you see the exposure levels that modeled that you have with rifampicin once a day, clarithromycin twice a day, and also amoxicillin clavulanate twice a day. This is an example. And we actually test different options, right? And what we found in here, what we see is the probability of target attainment of at least more than 90% of exposure of amoxicillin clavulanate, which would ensure activity of amoxicillin clavulanate. One thing that we are seeing, for example, the best performance, is that rifampicin twice a day at 10 milligrams per kilogram is the one working better, which is actually makes sense with the trials with high RIF. Okay? But what we are seeing is also that rifampicin normal dose with amoxicillin clavulanate with or without clarithromycin is equally effective. And an important thing is that we need the twice a day, because if we administer amoxicillin clavulanate only once a day, we are not meeting the criteria. Okay? So now going into the current trials for Buruli ulcer. Right now there are 3 clinical trials ongoing. The first one is this, Buruli Nox, is led by Richard Phillips, here to my right. And it's actually comparing a standard treatment with and without a special dressing that generates nitric oxide. In this case, it's a PROVE phase 3 trial, and the primary outcome is the rate of healing. Okay? But this one is not aiming to treatment shortening. For treatment shortening, there are currently 2 trials. One, again, led by Richard Phillips, is the high RIF trial, Buruli, in which they are combining they are combining rifampicin clarithromycin plus a coating, a DACC coating, that is actually a coating that is removing the bacteria from the wounds, and is compared with the high RIF of 20 milligrams per kilogram. Here is doubling the dose, although we have seen in tuberculosis that it couldn't go up to 35. Here, the primary outcome is time to clearance of viable M. ulcerans cells. And then there is the trial that Christian Johnson just presented before, in which we are adding amoxicillin clavulanate to rifampicin, clarithromycin, and to try to shorten from 8 to 4 weeks. And in this case, our primary outcome is cure at 12 months. So this is all right now, just to announce that we have a new website. So it's building it. You can go for it. And that's it. Thank you. I think what we can do now is I'm going to pass to the next presentation. Is from Gerd. That actually someone has to be there to put it. I can go.
No, two.
I have it. Yeah, it's working. Yeah, Q203 is a prototype example for drug repurposing. It initially developed for tuberculosis. It's an orally active small molecule. It blocks the cytochrome BC1 complex, which means the bacteria are no longer able to respirate and the ATP production is down. It's two important elements. It has received orphan drug designation by FDA. And what we very recently heard is that the TB Alliance has entered into a license agreement with Quirient and is now developing the compound for tuberculosis, but also for other non-tuberculosis mycobacteria. There are 3, to my knowledge, published clinical trial data. One is single oral dose, and there 10 to 800 milligram were well tolerated. Then there's a study with daily for 40 days, 20 to 320 milligram, also well tolerated. And there we also have data on the concentration in the serum. And there was a phase 2 trial on newly diagnosed TB patients, which showed that increasing doses of the compound were associated with greater reductions of viral mycobacteria in the sputum. Now, very briefly to the treatment of borreliosis, we just heard in the old days, traditionally it was surgical excision, which meant you may have had a small lesion and you had to cut away a wide margin of healthy-looking tissue. And I remember the days when all clinicians said antibiotics don't work. We have tried everything. And I think part of the story is that the lesions may appear to get worse under treatment because a closed lesion may ulcerate or an ulcer may grow larger. And I think that's primarily because a lot of subcutaneous tissue already is dead and you're losing this tissue and the treatment cannot stop that. And I think looking into this time, it was very important that there was a mouse footpad model and that it was seen that rifampicin in particular was effective. And then we have seen clinical trials and then the provisional WHO guidelines with streptomycin, rifampicin, and finally clarithromycin, rifampicin. And as for all other bacterial infections, the treatment takes long, and it would be nice to have a faster acting and simpler treatment. And the question is whether telecebac is fulfilling this. And it was a very positive surprise that it's against Australian and African Mycobacterium ulcerans about 10 times more effective than against M. tuberculosis, not against the Japanese strains. And the concentrations found in patients are quite in the range that would kill Mycobacterium ulcerans. So very positive result. The next question was, why are the African and Australian strains more sensitive than the Japanese ones? There we have to look into the history. So there was a Marinum progenitor, and ulcerans has at some stage taken up the plasmid that encodes for the enzymes for mycolactone synthesis. And then we've seen, or we are seeing, genome reduction, so the genome is much smaller, and there's an accumulation of many pseudogenes. So we have reductive evolution, and we can roughly distinguish two major lineages among the human pathogenic Mycobacterium ulcerans. The one lineage is Australian and African, and the other is the so-called ancestral lineage, and which are found in Asia, in Japan, for example, South America. And both lineages apparently went through different patterns of genome reduction. And the ancestral, typically you find single cases, maybe 2 cases at the same place, but maybe quite far away from each other. And in Australia and West Africa, the disease is often very focal, and you may have a quite high incidence in particular communities. Now, the story is that both the African and the Australian strains have a mutation in a second oxidase, the site BD, and this is active in M. tuberculosis, and it's a bypass. So Q203 only hits the major oxidase, and that causes that M. tuberculosis can better survive, while we have a complete shutdown with M. ulcerans because we have a stop codon in the BD oxidase gene. So that is a very early event, apparently. So as far as we can tell now from hundreds of genomes of African isolates, this is common to all of them. And Q203 does what we expect. It reduces oxygen consumption, and it causes ATP depletion. The next question was, does it relate to efficacy in the footpad model? As I said, I think we think it's predictive for the situation in humans out of experience with rifampicin. And it turned out that a treatment 3 times per week for 1 month caused a dramatic decrease in footpad swelling and a complete killing of the bacteria. We also had a look then whether 4 doses over 4 weeks are sufficient. The half-life is quite long, and this seems to be possible. And we also tried a one-shot treatment with a very high dose that would be the dream for the human situation, but may not relate in a situation for humans. And we have now data from 3 different groups working with a mouse footpad model. There's also information about co-administration with other drugs. There are data on immunodeficient mice and different dosing schedules and treatment durations. And if we look into a consensus, it looks as if the bacterial load is diminishing very rapidly, so it kills ulcerans very efficiently. A second drug does not significantly increase efficacy, so in principle, a single drug treatment could be considered. And the doses used in the model are within the range if you compare per weight with the doses used in the clinical tested regimens. And one can conclude that it's very likely that a shorter dose, and maybe we talk about 2 weeks or 4 weeks here, may be possible. As I said, a single dose would be the dream. Then you're coming into a scenario like for JAWS, but that's definitely not the thing you would test in the beginning. For Africa in particular, it would be a bit the vision to have a combination of a point-of-care test with a short treatment to capture early cases. That's for a long time was the strategy of the control programs, and we have to see whether such point-of-care tests will become available. We have 3 different ELISAs, which we are currently evaluating. In the end, they have to be converted in RDT, and we heard today in the morning that this is not trivial, and you may lose sensitivity with certain platforms. Now, if one discusses issues to address that have to be addressed for Buruli ulcer treatment, one has to think of blood concentrations, timing, and dosing. The question whether the drug should be combined with other compounds. One has to look into safety in children. In Africa, a high proportion of patients are children, and one should consider the combination of point-of-care diagnosis with short treatment. And one has to think of trial sites. Africa and Australia are the most likely, or are the 2 continents where it should be tested. And with this, I thank you very much.
Thank you very much, Professor Gert-Pluschk, for your presentation. I would like now to introduce Paul Johnson, and then we will open the door for discussion. Paul Johnson, please.
Good evening and thank you. I think we saw my presentation briefly before. Aha. Merci, Christian. So look, you've seen this image before, but I just wanted to remind everybody that in Australia we do have more than one endemic area, one in the far north, but the main one is down around Melbourne in the temperate area, and that's producing virtually all the cases that we have at the moment. Can you do suivant? Doesn't seem to want to go. So things have changed enormously since our team first developed the IS2404 PCR back in the mid-90s. Next slide. And the disease is well known, it's often publicised. The PCR is available through many different pathology services and hospitals, and lesions therefore are often diagnosed pretty early. And if people, and it's free now, so that there's no real barrier to access to diagnosis. And we find that any time you can see an ulcer, if you can get any biological material on your swab, it'll always be positive by PCR. And if it's not positive and you've got a sample you can see, it'll be something else. And I have had people refer me cases of Buruli which are PCR negative, and some of them have been leishmaniasis contracted overseas, not in Australia. Occasionally we do have plaque lesions and we need a biopsy for those, but most of them are ulcers. Suivant, merci. The next big revolution that we all know about and has been discussed is surgery being replaced. Next slide, please. And this is a photograph that John Heyman provided. It's the leg of one of the original patients from Bairnsdale who was described in the original paper that described Mycobacterium ulcerans for the first time from the far east, or the eastern part of Victoria. And that happened to her when she was a young girl. In that paper, you can only just see it in white as a quote, and that is the only effective measures were wide excision. And she had her wide excision, and all through her life she lived I'm not sure if she's still alive, but John Heyman isn't here to confirm the facts, but she always regretted this thing. She always felt scarred. She felt she couldn't dance, she couldn't show her legs, and it was something that went with her all her life. And for her, it was one of the major events of her life. Next slide. But these days we know we've got this great simple protocol, and this is just a screenshot from one of the guides we use in clinical infectious diseases. It's the Sanford Guide, and that's what it says now if you look up Buruli ulcer. And in my practice, I always use rifampicin and clarithromycin. I think most doctors do now in Australia, although some, the group in Barwon Health sometimes use ciprofloxacin instead of clarithromycin. But I think this is now the dominant regimen used to treat. Next slide. And you can see it's pretty good. So this young man, healthy, fit, on no medication, he's a surfer, gets this thing on his ankle. We can prove that it's Buruli ulcer in a day with our PCR. We gave him 8 weeks of oral rifampicin and clarithromycin. He had no side effects except that his urine went orange. That was the only thing he thought was strange, and we know that's the rifampicin in the urine. Complete recovery, so extremely simple compared with the old days of surgery. Next slide. And the Barwon group have got quite a large cohort that they regularly publish on, and you can see from this that in their hands only a very small percentage of people fail antibiotics, so they're highly effective. And they did find 7 out of 430, which is less than 2%, who, according to their definition of a second positive culture within 12 months, failed. So tiny failure rate, really. And the risk factors they identified were being immunosuppressed or male or being overweight. Next slide, please. Now, I just want to take you through this is a typical Australian case now, so not a child, but this is a woman of 85 who lived in a non-endemic suburb and was convinced she'd got this locally because she was locked down all the way through 2021 from COVID, and she noticed this first in December 2021. And she said she hadn't been anywhere for a year, but in fact, on close questioning, she did have a short trip to Point Lonsdale for 4 days at Easter, so that's April. And it just reminds you that it's got a very long incubation period and very short exposure time to get infected. Next slide. So we followed the regimen, the antibiotic guideline, but she's also taking rosuvastatin, atenolol, and mirtazapine, one for cholesterol, one for blood pressure, and the other one, her GP, her family doctor said, she doesn't really need it, it's just for sleep. Next slide, please. But if you look up the interaction checkers, you can see this is not a good combination to have if you want to start clarithromycin and rifampicin. There's lots of drug interactions. Next slide, please. And just a few of them, clarithromycin and mirtazapine, one drug boosts up the levels of the other. You end up with toxicity with rosuvastatin, and you end up with QT prolongation as well with clarithromycin and mirtazapine. And it's in red, and they suggest you don't use these together. Next slide, please. So as per her GP, we weaned her off the mirtazapine, gave her a couple of weeks, reduced to rosuvastatin, started clarithromycin and rifampicin, and within 5 days she was extremely unhappy. She was developing insomnia, dysphoria, and she herself stopped all her medications. Next slide. So we had to immediately restart mirtazapine, and her dysphoria went away. And we arranged a surgical excision, and I also gave her 4 weeks of rifampicin alone. But even then, the dysphoria came back, and we also know there's yet another interaction there that rifampicin induces the metabolism of mirtazapine, so therefore if you really need the drug, you have to boost the dose. So we increased the dose, and she was happy again. Next slide. And so here's her surgical scar, which I would have thought she would have been pretty unhappy about compared with the size of the original lesion. Next slide. But she thought that was great, and she was very pleased when she finished her 4 weeks of antibiotics, and she said she never wanted to see me again. Thank you. So we also know from this, the Barwon cohort that antibiotic intolerance is not rare in Australia. So in this cohort of 337 patients at the time they reported, about 1/5 had side effects leading them to have to stop at least one drug, and 11 of the whole group actually needed to be hospitalised due to side effects, and having poor renal function or being female seemed to increase this risk. Next slide. Other things I'll just quickly go through, next slide, is that we still find a role for surgery. So this is a plaque presentation. You can see it evolving over 4 weeks, and you can see how hard it would have been to diagnose when it was first presenting in that first picture. 4 weeks later, it looked like the picture on the right. It was diagnosed as Buruli by PCR from a biopsy. Next slide. We started the human rifampicin and clarithromycin, and within 2 weeks he had this terribly painful inflamed leg, which is the classic paradoxical reaction, which is what led the earlier Buruli doctors to come to the conclusion that antibiotics didn't work, because they don't. Look at that. It's a whole lot worse. And if you're not prepared for this, the patient totally loses confidence in you. You need to warn them that this is going to happen. So what would we do next? Well, we could give steroids, but in fact what we did was we got a surgeon who knows about this disease, very conservative, quick general anaesthetic. She made an incision and then broke down all the tissue underneath the skin and let it drain, and that's his final result. So there are still ways of combining surgery with antibiotics to get really good results. Next slide, please. Next slide, yeah. Next slide. And then the other problem we still have is dressings. So he's a man of 72. He's on immunosuppression because he's got polycythemia rubra vera. Next slide. We start him on treatment. Again, that classic paradoxical reaction. It all breaks down. If you didn't understand Buruli ulcer, you would again be sure that the antibiotics were not working. Next slide. He did have some steroids, but most importantly for him, while his drugs were free from the hospital, he has to pay for his own dressings, and he didn't want to stop work because he was very dependent on his income. He was self-employed, and he was paying $55 for that box at the top, and I've got a different patient there in the picture at the side, but that's a typical dressing in my clinic anyway, where we use Sorbact to put on the ulcer, and then we put a absorbent dressing to keep the wound moist and covered. And that's very expensive. And if next slide, please. He needed to get cured. He's completely cured, full range of movement, but he had 3 months of antibiotics, 1 debridement, 1 failed skin graft, 2 years of dressings, and then it all healed by secondary intention. Next slide. And now, as I said at the beginning, we get these people who've got tiny lesions because the PCR is so available and the publicity is high. And this person's presented with 3 things on the back of his leg. Each one is individually PCR positive. So he's got 3 simultaneous small Buruli ulcers. And all of those who've been following the mosquito story, it's so clear now that this is how it's transmitted in our part of the world. Next slide. And so we obviously are interested in the shorter courses. Now, the Barwon Health Group have looked at this, but not in a randomised way, and clinicians have picked patients. But basically, they have shown that in the 207 people who had 6 weeks instead of 8 weeks, they seem to get a perfect score of cure compared with 8 weeks. But I don't think they're really comparable groups, and the reason I say that is because the healing rates seem to be slower in the 8-week group compared with the 6-week group, which doesn't really make biological sense. So it suggests to me actually that they were more severe in the 8-week group. But anyway, there's good evidence there that 6 weeks may be effective for these smaller lesions and safe to use. Next slide, please. And then finally, next slide, there's the potential for major increase. So this is now quite newsworthy in our part of the world, and it's causing a lot of anxiety. Next slide. And you've seen this graph before. So disease was made legally notifiable in 2004, And since 2004, we've had almost 3,000 cases. And on the average for each year in the last 6 years has been just under 300. You can also see dents in the curve. One of them, the big one early, was due to a long period of drought. And then in 2020, everyone couldn't move around, so COVID had its impact. Next slide, please. And then finally, we have this new worrying movement into our really dense, proper urban settings. So that highlighted area is the local government area around West Brunswick, where we've now got local transmission, and that's just a Google photograph showing just how dense the houses are. That's real suburban Melbourne. And if borreliosis doesn't seem to have a limit now, there doesn't seem to be any reason why it won't continue to spread. Next slide. So my last slide, current treatment needs in Australia. Well, we've got small PCR positive lesions often. It seems that 8 weeks is way too much. We would love to have shorter course therapy. We have older people who may be intolerant and there are significant drug interactions. We still haven't quite worked out exactly how to use surgery and medication together optimally. We've got lots of expensive and varied wound dressings and no real guidelines. And we have, finally, quite large populations at risk. The trend in Australia is towards increase, unlike Africa. We have outbreak potential in our Australian cities and all of our Australian cities, really, with mosquitoes, humans and possums. And who knows what's going to happen, but I'm just going to say maybe there might be 1,000 cases per year by 2030, unless we think of some way of stopping it. Thank you very much.
Thank you very much, Paul Johnson. Thank you to all the speakers. Now we will open the door for discussion. But before, let me say that thanks to the huge work led by Dr. Kingsley Aseido and all the control program and all the BU communities, we try to standardize the treatment of Buruli ulcer. And we have some components of this treatment, including antibiotic treatment, wound dressing, debridement, and skin graft, and also prevention of disability. So antibiotics treatment is a component of this treatment, but not alone. So we have to have in our mind that we also need to take into account the fact that we need also wound dressing, skin grafting, debridement, when necessary for the management of patients, and also prevention of disability, because we all know that if we care patients with deformity is not a good matter. Now, coming from antibiotic treatment, please, Stéphanie, est-ce que tu peux montrer la diac de la discussion? La dernière. Okay. Before opening the door for the discussion, I think that we have some key questions to be addressed. And actually, we have seen some presentation about the dose of rifampicin and also combination with antibiotics to develop synergy. And we need to discuss actually what is the optimal combination now. And various clinical trials are going on, and I think that it is very important to combine information from this ongoing clinical trial to make the stock and to know where we are, but also where we want to go. I think it is very important. If not, we will waste time, waste resources. We also discovered that the epidemiology and the management of BU is different from Africa and Australia, and I think that we need to adapt the management of BU in the context. We also hear about Telasebek and his effectiveness in the treatment of BU. What will be the future? How we can plan the future? And given the scenario that actually in many countries in Africa, Benin, Côte d'Ivoire, probably also in Ghana, the number of BU cases is decreasing, while in Australia, the picture is completely different. So how we will manage this when we want to make recommendations for the treatment actually and for the future? I think that we need to take all this into account during our discussion. And we know that the regimens proposed and recommended by WHO is effective. But what will be the future? What will be our priority? Is it to reduce the duration of the treatment? How we will plan all this? So I think that all this issue is very critical and very important, and we need to discuss. And at the end, how can access the new medicine and treatment can be assured for all patients? Because it's good if we can have very strong, effective treatment. But if it is not available for poor population, I think also that is a problem. So we need to take all these into account in our discussion. So I want to open the floor to the discussion now, and I think we have some key points to be discussed, and the floor is open. So we can open the floor, maybe by my right, who want to speak to question here in my right. Yes, please. Okay.
Yeah, I'm totally blown away by the mouse data and super subjective in thinking that this will change everything. I would make a plea for monotherapy because it's fortunate that every infection comes from the environment. So if you create resistance, you're not going to spoil the drug for human-to-human transmission doesn't exist. And in the trials, you can, at the end of treatment, try with deep sequencing, see if you induced or selected for any resistance. And then I think if, as a clinician, because you treat, if you shorten treatment, you still have to anticipate potential worsening of the lesions. And so this question of, have I given enough antibiotic? People will have to sit tight if you give a short treatment and you trust that it's been sufficient. But if you give the regimen that was safe to TB patients, the 300 milligram once daily for 2 weeks, and try that, then you've probably given more than enough. And then in the infection model that here already got ethics approval, you can then try single dose and see if that does anything in parallel. And then EDCTP funds something similar in all the African trials as an add-on arm.
Thank you very much, Bauke. Other comments? Yes, please.
Just a comment and a question, but I suppose as the prevalence goes down and it becomes a rarer and rarer disease, it makes these human-controlled infection models more and more attractive in order to finally eliminate, eradicate, if it's possible. Well, probably not, because it's got a zoonotic reservoir. But my question was about the rifampicin and the amoxicillin clavulanic acid synergy. I might have missed it in the graphs, but does it need the clavulanic acid, or could it just be the amoxicillin, just in terms of stewardship and side effects and things?
Yes, it needs the clavulanic as well. But in those assays, clavulanic was at a fixed dose. I think it was 4 micrograms per milliliter. And then the concentration of amoxicillin is actually modulated in a dose response. But it's been demonstrated that you just need a certain level of clavulanic acid to actually exert the effect of protecting the amoxicillin from the beta-lactamases.
This one?
Just on that point, is that would be for TB, which has a beta-lactamase, but does M. ulcerans have one?
The MIC of, I'm talking from the top of my head, but the MIC of amoxicillin alone for ulcerans is higher than 64 microgram per milliliter, and when you add clavulanate, it goes down to, depending on the strain, to around 2 or something like that. So yes, it has.
Thank you very much. Just a comment, coming to the comment made by Bauke. You make a play for monotherapy, right? But from public health perspective, what is your opinion? Because these drugs are also used for leprosy, maybe for TB, and from this public health perspective, do you think that using monotherapy will be concern for other disease control program, or what is your opinion on that?
No, I don't think so, because if your patient would fail monotherapy because you've selected for resistance to telesibec, you have perfect rescue regimen with rifampicin clarithromycin, and it's super unlikely that your BU patient was harboring subclinical TB or leprosy at the same time, so I would have no concern.
Thank you. Other comment, please? Okay, Phil.
Sorry. Very enlightening presentations. I was wondering, unless I missed this in the various presentations on treatment of BU, has bedaquiline been tried in treatment of BU? And that's the first question. And then the second question is there merit in considering joint or combined trials of BU and leprosy, either in areas where it is co-prevalent, or for the sake of, say, funding, it might be more attractive for a funder to fund a multi-NTD trial rather than a single NTD trial, especially if the cases are few.
Okay, I think that bedaquiline in treatment of BU is not, this clinical trial is not conducted until now. But yes, it's something we can consider, since now bedaquiline is considered for leprosy. And if we have co-endemic places where clinical trials are conducted for leprosy, maybe it's possible to consider this. But until now, we don't start clinical trial on bedaquiline on leprosy, on BU. Yes.
Thank you. I think another plea for monotherapy in telesibec in BU would be if you would not do monotherapy, but you'd add one active drug. And imagine telesibec does not work in BU, then the other drug would actually be a monotherapy, right? And then you may actually lose your backup therapy in case treatment would fail. And if you say, okay, then I would need to add a third drug, so you'd have 3 drugs, then what is the advantage for the patient? And that is, I think, my second point, because we say, is there an optimal combination? I think that what the patients or the community members want is a very important factor in this. So I think we should include their opinions, 8 versus 4, 8 versus 2, 1 tablet, shorter versus 3 different drugs. What is what the community members want? And as far as what I've heard, is mainly their main worry is that the time to healing should be shortened dramatically. But that can, of course, differ, especially in the settings, different settings versus Africa versus Australia. But I think we should definitely include community members and former patients in this decision. What is the optimal combination?
Okay, I would like to know the opinion of Kingsley about that, but before, I just want to know, actually, what type of information we have regarding the effectiveness of telesibec on BU in human. And also we need to know the pharmacokinetic of telesibec in human with Buruli ulcer, because I think all these issues should be properly addressed. But ideally, we know that as public health perspective, if you can cure a disease by one drug in monotherapy, it's good. But we need to study this asset properly and also see what will be the consequence of this strategy on other disease control program and what is feasible and what is not feasible. Maybe the national control program here, we would like also to know their opinion on that, but also those who manage, the clinicians who manage Buruli ulcer, because you all know that for BU, in the majority of places, it is not category 1 lesion. It is category 3 lesions where we need to go for wound care, dressing, and all these issues. So, Kingsley, what is your opinion on that?
Telasebek is not a drug on the market yet. It was developed by a Korean company, which has now been acquired by the Global TB Alliance. Dr. Eugene Son and others are here from the Alliance, so we had some meeting this afternoon. They can also update the audience on that.
I think also, Vim, do you have some information regarding use of Telasebek in leprosy?
No, I haven't so far, no.
Yes, Paul?
Yeah, there has been a mouse model study in leprosy by Dr. Ramanuj Lahiri et al. In the Baton Rouge Center, and it was very effective. And I think they're doing follow-up studies looking at relapse in leprosy.
Kingsley said that we have some people from Global TB Alliance here. Can you give a... Yes. Okay, please.
Hi. Thank you. So the three of us are from the TB Alliance, 1, 2, 3. And we, first of all, are very appreciative that this meeting is taking place only a few weeks after we acquired the rights to Telasebek from Curient. And as Kingsley mentioned, we had a smaller meeting earlier with several of you. But just I'll repeat a few things here just to update you. We are definitely in the learning phase. We have a lot to learn here. We work on TB, which is obviously mycobacterial, but is a very different disease than Buruli and leprosy. We're very excited and optimistic about the compound for reasons that you have all heard. It's a very, very, very potent compound against M. ulcerans and lepri, even more so than against TB. And secondly, those two organisms have fortuitously lost the BD oxidase pathway, and so the theoretical efficacy against Buruli and leprosy is in fact potentially greater than that for TB. And as if you've also heard and read, there is very compelling. Are you signaling me? No. There's very compelling mouse data. Now, on the other side of the coin, being a drug developer for a couple decades, I'm also very humbled by all the things that can go wrong in drug development, no matter how promising your preclinical data are. And we're in the process of evaluating things like the synthesis of the compound, which needs to be efficient and cheap, because ultimately we're looking at delivering a product that can be economically within the reach of resource-constrained settings. And that's a whole nother body of work that lies ahead of us. We are in discussions with a number of you on the design of clinical trials going forward, with all the usual questions about what's the right dose, but also what are the drugs, if any, to combine with Telasebek, and what is the duration. And it's not quite, I don't think, I think it's a little maybe simplistic to say the shorter the better, because frankly, if a longer treatment regimen results in a faster healing time, then it really is the time of treatment plus the time of healing that needs to be considered, and ultimately is what is going to be a burden for patients and healthcare systems. So we have a lot of work ahead of us, and we're relatively early in our understanding of the data and in our work, but we look forward to working with all of you to advance this product and make it available as soon as possible.
Thank you very much. Other comment, please?
Thank you. I would like to react on the treatment. It is very nice, sorry, very nice, we would like to improve the treatment. But we have to take into account that maybe the decreasing of patients in Africa may be virtual, not real. And because some few years ago in Australia, there were few cases. In Africa, there were plenty of cases. We don't know really the transmission of BU in Africa. Maybe it's very nice to improve monotherapy, gel therapy, all is nice. But pay attention that if we change greatly the treatment, because currently, as a clinician, I think that the treatment currently is nice. Maybe it can be improved. But pay attention, don't say that because patients in Africa are reducing, maybe we change the treatment a lot. We don't control, maybe it's not yet controlled in Africa. Maybe in Australia, I don't know, but in Africa, it's not under control. So pay attention on that. Do not change greatly things because in Africa, where we pay attention, we have means to go and detect patients. We can find a lot of patients in some places. So the decrease is not real already.
I definitely agree with you. We need to continue surveillance of BU, and I think that clearly all the control programs should maintain the BU surveillance within the country, within the endemic communities, and we need to follow because really we don't have long-term perspective about this decline of the number of BU cases in our country. So definitively I agree with you. Other comments? Yes, Santi?
So this is a couple of questions with Telasevec. Is it defined in TB how you generate resistance to Telasevec? That would be the first question. And the second is in line with what was mentioned about the combinations. This is something to consider because, for example, for the RIF clarithromycin, it is, at least for the in vitro studies that we are doing, and I mean local impressions for clinicians, the contribution of clarithromycin is somehow being questioned in that combo, in the sense that the efficacy is mainly driven by rifampicin, which somehow also support the maybe one drug could be only used for Buruli ulcer. But from a public health perspective, I don't know if we want to actually take that risk in the sense. So going back to Telasevec, the question is, it's been defined what are the best companion drugs for Telasevec? Because in here, if a companion drug is being found for Telasevec, it should be something that is already available there. I don't know if rifampicin, if you mix rifampicin and Telasevec, if you make like a super potent combination. I don't know if there is any data on that.
Thank you. I'm Rachel Simmons from the University of Surrey in the UK. I just want to come back on this point about wound healing and how important that is to people who are suffering from Buruli ulcer, both in low middle-income countries and in the global north and Australia. That the focus of this discussion so far is on antibiotics to sterilize the wound. But wound healing may be more complicated than just sterilizing the wound of bacteria. So I think there needs to be a discussion around host-directed therapies to enhance wound healing alongside antibiotics as part of this discussion of the future of drugs for BU.
Thank you for your comment. Yes, this is why before we introduce the discussion, we explained clearly that antibiotics is one component of the treatment of BU, but we need also to consider wounds management, debridement, skin graft, and other components such as prevention of disabilities. Tim, you want to say something?
Yes, thank you. I was wondering also in that discussion on monotherapy versus multi-drug therapy, has intermittent therapy been either tried or are there theoretical considerations on that? We are currently conducting a trial for enhanced chemoprophylaxis of leprosy using rifampicin and clarithromycin at 4-weekly intervals. And we've worked with the modeling team at the University of California who specialized in TB modeling, and they say if you use it at that sort of interval, then rifampicin, the effect on the enzymes, and that may reduce the efficacy of other drugs, is actually, it goes back to zero in about 2 weeks. And so if you use it at longer intervals, like 3 or 4 weeks, then you don't have that problem. And I heard that mentioned in one of the presentations. So I was wondering, has that been considered at all, that you could do an intermittent therapy, because that would be, from the patient's point of view, that would also be user-friendly.
So anyone correct me if I'm wrong, but I think that for Buruli ulcer that has not been considered. But it's an interesting point, that one, but I don't think there is neither even in vitro data generated on Buruli ulcer to actually confirm that hypothesis, that you can be actually doing intermittent treatment. But it's an interesting option.
I think that maybe we can summarize our discussion about Telasebek. Before that, I don't know if you have someone here have other comments.
Yeah, just one question, because I didn't get an answer about the question whether there is how is the resistance associated in TB with Telasebek, if that is known, and if there is any known good companion for Telasebek.
I can just say from our mouse studies with Buruli ulcer, combining other drugs with Q203 didn't further enhance. The impact of Q203 alone was quite great, and if you add clofazimine or bedaquiline or rifapentine, in different combinations, they were all basically the same. Yeah, I would I don't know if it's been published yet, but so far in TB, the drugs that have been tried have not had a benefit one way or the other. What we really need is a BD oxidase inhibitor for TB, and it's a natural in ulcerans and lepri, but unless we have a pharmaceutical BD oxidase, it may be difficult to have an impact in TB.
Okay, so what we can say is that, okay, Telasebek is a promising drug for the future, but we need more information, we need more studies to document the efficacy of Telasebek in human, for BU as well as for leprosy. But actually, it is the compound is under development, and it is very difficult to make a decision from public health perspective now. But we may consider further studies to have more information of these compounds in human regarding leprosy as well as TB, as well as ulcers. I don't know if this type of conclusion is suitable for all of us. Kingsley?
Yes, I think it's correct that it's not something that we can start to use tomorrow. It's going to take a bit of time, but we will continue to engage with the Global Alliance on the way to develop it for the future. Yeah. At least for now, we are not bad. The rifampicin and clarithromycin work very well, so we are not handicapped. But if we can find a shorter treatment, that will be helpful. On the issue of declining cases, yes, I agree with the comments given that maybe except Australia, where perhaps the surveillance system and access to health care is very good, so maybe they are not missing too many cases there. But in Africa, I think that no country can guarantee for sure that they are not missing cases. So we have to always explain the decline in the number of cases with a bit of caution.
Yes, Kingsley, you're completely right. For National Control Program who are here, please maintain the active case surveillance and the surveillance system for BU for the coming years. We need to have good program. If not, we will lose all the effort we made in the past. Okay. Okay.
Just on this, a few cases in Africa, I'm wondering if those running trials in Ghana and Benin would be interested in joining forces for this EDCTP call on diagnostics, where it will be stronger if you add novel diagnostics like were presented here in those trials, and then also add a work package proof of concept with 20 patients on Telesebek. That would be a fantastic way to generate more data and advance things both in Africa and in Australia.
Thank you, Bauke. It's something, it's a realistic suggestion, and I think it's something we can consider. Thank you.
What is the call on?
EDTCP.
EDCTP just just launched a call on point-of-care diagnostics in a two-stage format, so letter of intent and then a full proposal by invitation.
And what do you have in mind? What will be the ask? Because I'm just trying to understand what was presented this morning and whether there is anything new with that.
I would say that Sandeep's biomeme with the RLab target would be easy for IS 2404, and maybe one step back from the RDT, but the antibodies against mycolectone from Gert make a lot of sense. I also would be interested in looking at the volatile organic compounds, the smell diagnosis, but that's not going to carry a proposal by itself.
I was expecting that by now, with the COVID, all the developments for diagnostics that happen so rapidly, particularly the molecular side, we'll have a molecular tool that will no longer require this 3-room separation of this before you analyze. Just put sample in a tube and it will run all the 3 rooms in a go. I mean, we have to go past, you need this room, there's contamination in this room, you have to clean it. This is old technology. Why hasn't this changed? With all the innovations that came around COVID, we cannot go back to the old, you have 3 rooms for PCR, that's not so. We have to keep this contamination, decontamination, running. No, we should have gone past this with a portable equipment that will process everything in the three rooms to avoid all these problems of contamination and things. Anyway, it's not for you guys, but I just want to vent out my anger that we couldn't succeed and now COVID is over. There will be no money to develop new tools again.
I think Bauke's point was that what Sundeep presented was exactly that. The biomeme is indeed a closed cartridge and a very rapid form of qPCR, and it could potentially work for both BU and leprosy. So I was going to suggest if you do that EDCTP submission, can we then combine that with leprosy?
So we agree that we need more studies on the subject, and if we can continue discussion to come to the sort of action, it will be good. Okay. Now coming now to the ongoing clinical trial. Actually, what are going is some trial in Ghana, what we have done in Benin, and what we want to expand in Togo and Côte d'Ivoire. So you want to make a comment on? So I think that what we can say is that we need to continue this clinical trial to have the outcome, and based on that we can see how type of recommendation we can make. And then if we can also think to a joint call to improve what we are doing now, why not? So all these possibilities should be considered. So I don't know if you have other comment or other. Yes, Kingsley.
So my only comment is that, at least for Buruli, people should understand that the drugs alone not sufficient for the healing. So the wound care part, others are very also important components. We don't need sophisticated wound materials, basic one, but the principles of wound care, when I'm in the field, I look at the way they dress wound, no infection control, nothing. We have to train health workers on that. I mean, you can take the medicine that will kill the bacteria, but the whole wound healing will take longer than the duration of the antibiotics. So we have to take that into account. The other point is that, and for those involved in trials, to move from trial to application is not always a simple leap. Yeah, it may succeed or may not succeed. You may succeed in the trial, but it may not get to the patient for different reasons. So it's always important. I'm looking at point number 7. Always important at the start. Well, if I were doing the trials, which unfortunately I don't do, you should ask yourself, if we succeed, how will the patient get the drugs? Always ask that question first before you start the trial. The trial, you can do it for academic interest. But the question is, if you succeed, how will the patient, who is going to buy the drugs for the patient? That should always be an important consideration.
Okay. So actually, in the trial that we are running, we actually follow your recommendations. And the design of the trial was actually trying to be as close as possible to what is the real life and the real scenario. And one of the ideas of actually using amoxicillin clavulanate is that if it is working, it is very easy access for the national control programs to start implementing it right away.
Thank you very much. Let's summarize our session. And first of all, I think we all agree that we encourage national control program to continue surveillance of BU in their countries, because we can't say the number of BU cases decrease and we will finish the job. No, I think it is very important to maintain the surveillance system. I think that also we need to continue the ongoing clinical trials, and when we will have the result, then we can see how we can use these recommendations for practices. And then we need also to continue discussion to see how type of study we need to conduct, but taking into account that at the end, we need to conduct some research related to control, because if we have good result and it is not possible for us to transfer to control because the drug is too expensive and not available, it may be only to publish paper and it's finished. No, this is not what we want. We want to conduct research, we want to make effort, and after that it will be useful for our communities. So I don't know if you have other comments. If not, I will like to thank you. I would like to thank you very much for your attention, and thank you very much. Okay, thank you. Thank you very much. Yes, please come. We will make a photo. Eh? Yes. Yes. I took a
picture of them and of you.
Okay. You have my...